everyone else's.
Rawad, this is both Helminths and Protozoa, صح?
Yes, sir. Protozoa and helminths, inshallah. All right. Can you guys see my screen?
Yes, sir.
All right. So, assalamu alaikum, everyone. My name is Rawad Turko. I'm a third year medical student. And today, inshallah, we'll be talking about parasitology, which are 5 lectures. So, they're the Protozoa lectures and the Helminths lectures from your POD block. Now, this one's a little bit different than all the other PAL sessions that I've given in the past, in that this is more of a crash course style, rather than it being a lecture. So that means that I'm going to need you guys to be as interactive as possible. Okay, I want us all to get out of this session. You know, this should be like a good review for you guys for parasitology. So I want you guys to follow along. You guys should know this information already, inshallah, and just try to be as interactive as possible. I have a few questions mixed in there, few pictures that you guys should take a look at and remember. And yeah, without further ado, inshallah, let's get to it. So here are the objectives. We're going to be just running through some terminologies. We're going to be introducing parasitology in general. And then we're going to be going into GI protozoa, and then blood protozoa, and then tissue protozoa. And then we're going to be classifying helminths, defining what a helminth means. Then we're going to be getting into the different types of helminths. So we have nematodes, cestodes, and trematodes. So let's get started. First of all, just for some quick introduction, we have parasites. That's what we're going to be talking about. Now, parasites, we can classify them in a few different ways, but I'm going to focus on the way that's pretty important for you guys. It's for your guys' blocks. We have something called an obligate parasite. An obligate means like basically it has to. So an obligate parasite means it cannot survive outside of the host, because as you guys know, a parasite is something that sort of feeds on and lives on another host. So an obligate parasite is a parasite that cannot live outside of its host. Facultative parasite, it's a parasite that can switch between free living and a parasite. So these are mostly your amoebas that we're going to be getting into later on. And then we have our accidental parasites. Now, these are parasites that typically you don't find in humans. Typically, you find them in other animals and other mammals and organisms. But maybe if a human ingests some of this parasite's eggs or something like that, they can accidentally end up in a human. So these are the 3 types of parasites that I want you guys to focus on. Okay, now getting into hosts. So we have the definitive hosts. Now this is the host where the sexual reproduction takes place. Okay, the intermediate host is the host in where asexual reproduction takes place or no reproduction at all. So for example, we know that we have a parasite. A parasite can basically reproduce either sexually, that's through sporozoites or male, female gametes and all those types of things, or it can reproduce asexually, either through budding or by binary fission, stuff like that. So your intermediate hosts are where you're going to find your asexual reproduction. So for example, here is in Plasmodium falciparum. Okay, so that's in humans, falciparum basically reproduces asexually. And your definitive host would be something like your helminth. So those would reproduce sexually inside of the human body, okay? Again, these are just to knock out a few of the terminologies. That's why we're flying through this pretty quickly. Then we have the reservoir hosts. The reservoir hosts are the asymptomatic carriers. So they just carry these parasites and transmit them to other organisms, and they don't have any symptoms. Now, the transport hosts are also transfers of the parasites, but no multiplication of the parasites takes place in the transport host. So the difference between the reservoir host and the transport host is that in the reservoir host, you will see some multiplication. Okay, so the parasites will multiply. They will reproduce, whether it probably would be asexually. But in the transport host, you would see no multiplication. It would just be, transport of the parasite. And then again, the accidental host is the same concept as the accidental parasite. Okay, now we have life cycles. So a parasite can either have a direct or an indirect life cycle. A direct life cycle is when it just uses one host. So that host would be the definitive host. So when I say that something has a direct life cycle, it means that it only has the definitive host where the sexual reproduction takes place. Okay, if it has an indirect life cycle, it means that it basically jumps in and out of 2 or more organisms. So one of those organisms would be the definitive hosts, and one of them would be the intermediate host. So let's say, for example, a parasite reproduces sexually inside of, for example, black flies. And then once a black fly bites into a human, then the parasites can enter the human and they can reproduce asexually. So that would be the intermediate host until again a black fly picks up the the parasite again and then reproduces sexually. So that's how it goes. So either direct or indirect. Okay, so that's the foundation. It's very quickly we're going to go through it. Now we have the basically parasite, sort of what two types of parasites we have. So parasites can be either protozoa or helminths. Protozoa are single-cell organisms. Helminths are parasitic worms. Simple enough. Now we can classify protozoa based on their movement. Now, this is not as high yield of a topic, okay, but it's good to remember because some of these names, the names of the different stages of the protozoa, sometimes are basically they're taken from the type of movement. Okay, so we have ciliates, okay, amoebas, flagellates, or sporozoans. Okay, so ciliates basically have cilia, which are these giant, like eyelash-like extensions from around the parasite, from around the protozoa. Amoebas have this little thing called a pseudopod, which is basically a little foot extension of the membrane that can allow it to move. Then we have flagellates. As you guys know, the flagella is one or more very long extension that allows it to propel. And then the sporozoans are basically immobile for the most case, so they don't move. Okay? Okay, let's get started. So again, this is the same slides. Okay, so let's get into the protozoas. We have first the GI protozoa. We're going to start with, by the way, guys, I want you to keep an eye on something. I'm going to move this down here. Actually, you know what? Probably up here is better. I want you guys to always look at this right here on my slides. Sorry, one second. Yeah, always look at this right here on my slides. That's where I'll have the protozoa name written down, okay? So right here. Okay, so the first one we're going to be talking about is Giardia intestinalis, or another word for it would be Giardia lamblia, okay? Now, this is the way I'm going to be doing my slides. So we're going to, first of all, talk about the class of the protozoa. So in this case, it's a flagellate. And another word for a flagellate is Mastigophora. Okay, and then we're going to be talking about the life cycle and then the transmission, and then population, and then signs and symptoms, and then a few extra information about the protozoa. Okay, and then we'll get into life cycle and all that type of stuff. Okay, so Giardia lamblia. The class is flagellate. So you guys can see these little extensions going out from the trophozoite. So these are flagella. So this is a flagellate. So another name for flagellate would be Mastigophora. The life cycle is direct. Okay, that means it doesn't have another host. It just has the host, which is the human. Okay, and how is it transmitted? It's transmitted through cysts in contaminated water or anal oral transmission. So where do you find this? You find this in homosexual men. Okay, so what are the population? You have hikers and homosexual men. That's where you can find Giardia lamblia. Okay, and what do I mean by cysts in contaminated water? So basically, when we talk about the life cycle, we mentioned that the Giardia lamblia has two specific stages: the trophozoite, which is this thing right here, and the cyst. Okay, now the cyst is the infective stage. That means when a human is infected with Giardia lamblia, that's because they ingested these cysts. So those cysts could usually are found in contaminated water. Okay, so that means, for example, a classic presentation would be a hiker, and this hiker is, he's going on a hike, obviously, and then he stops for a drink of water at a contaminated stream, and then he accidentally ingests some of these Giardia lamblia cysts, and then he develops giardiasis. So that's the disease, giardiasis. Signs and symptoms, this is very important, guys, is watery, non-bloody diarrhea and flatulence. Okay, so it's basically just abdominal symptoms. And why is it non-bloody? Well, this is because the trophozoites of Giardia lamblia, they actually have these things right here, which is called a suction disc. These suction discs allow it to basically attach to the intestinal wall, and it basically inhibits absorption. So sometimes what you can find also in these patients are fatty stool or fatty diarrhea, and that's because you have malabsorption of fats and nutrients and all those little things, and it would cause obviously diarrhea and abdominal symptoms. Now, this is important. The reason it's non-bloody is because these little suction discs and this protozoa in general, so the Giardia lamblia, it does not invade the epithelial wall. Okay, if it invades the epithelial wall, then it would cause bloody diarrhea. Okay, can you guys tell me, just before we get to it, what GI protozoa causes bloody diarrhea?
Histolytica.
Histolytica. Yeah, histolytica. So some extra information about Giardia lamblia is basically chlorination does not kill the cyst, but filtration removes them. Okay, so this might be something that you get in your questions a lot, so just remember it. And mammals can act as reservoirs. Okay, so like I said, reservoir host is somebody who basically just carries these parasites. Multiplication can happen, but they're asymptomatic. So any mammal can be a reservoir for Giardia lamblia. So this is the life cycle. Basically, like I mentioned, basically you're going to be ingesting these cysts. So this is again the infective stage. When I mentioned infective stage, this is important. So, and also, by the way, there's something different about Giardia lamblia is that the cysts can be both infective and diagnostic, and I'll get to that in a minute. So it basically starts when a human ingests these cysts, either from contaminated water or hands or anything like that. And then basically the cysts make their way down to the GI tract, where excistation takes place. So basically, whatever's inside these cysts, they come out, and it matures into a mature trophozoite. Okay, so this is a trophozoite. By the way, the word trophozoite, tropho, the prefix tropho, means basically sustenance or nutrition. So trophozoite is basically a feeding stage. Okay, so that's why it's the diagnostic stage also. Okay, so trophozoite would be the diagnostic stage. So again, like I mentioned, these trophozoites, using their suction discs, will attach to the gut wall, and then it would cause inflammation and malabsorption of fats. And how do you diagnose Giardia lamblia? You can either find cysts and trophozoite in the stool, or you can basically use immunoelectrophoresis, and you can find the fecal antigen. Okay, so through fecal antigen detection. All right, does that make sense? So again, cysts, you ingest the cysts, they turn into these things called trophozoites, and then again, you pass out more cysts in the stool. Okay, it's important to know what these trophozoites and what these cysts look like. Okay, so the trophozoite has two. I'm not sure why the pen is not working. So the trophozoite has two nuclei, as you guys can see right here. These are both nuclei, right here. I'm not sure why the pen is not working, but let me see if I can. Yeah. So again, these two nuclei, these are in the trophozoites, and again, this is what the cysts look like. It's more oval in shape. The Giardia lamblia cyst. Okay. It's important to know what these look like, by the way. Okay, and again, one thing that I like to do, guys, and I really suggest that you guys do this for your second and third years, is that now you're becoming more clinical. Okay, you're becoming medical students, you're focusing on more clinical presentations, and sometimes you'll get questions that look something like this. So it'll be you'll have to know what the diagnosis is through the clinical presentation. So what I like to do sometimes is I go on ChatGPT. That's why I included this logo. I go on ChatGPT and I ask ChatGPT to just show me the clinical presentation of a patient infected with Giardia lamblia or Giardia intestinalis, and that's what it gives me. Okay, so it's really important that you guys read this through. You guys know what the clinical presentation looks like, and you know how to differentiate it from other diagnoses. So this is the case presentation. So a 23-year-old male, Ahmad, presents to the outpatient clinic with 2-week history of persistent diarrhea. He describes his stool as greasy and foul smelling, and they often float. So what does this mean if they often float? What does that mean?
Fatty.
Fatty. Okay, so what does that mean? It means malabsorption. You have malabsorption of fats and stuff like that. That's going to cause fatty stool. He has mild to moderate abdominal cramps, blah, 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 blah. Not that important. Okay, mentions that he returned from a hiking trip 2 weeks ago and he drank untreated stream water after running out of bottled water. Okay, so now you guys get it. Okay, so he drank contaminated water and now he has non-bloody, foul-smelling, fatty diarrhea. What does that tell you? Giardia lamblia. Okay, and again, this is a little picture from first aid. So non-bloody, fatty diarrhea, campers and hikers, and the transmissions through cysts and water. And again, the diagnosis would be multinucleated trophozoites or cysts in the stool, or through antigen detection. Okay, don't focus on the treatment for now. Okay, this is just something that you should know. Okay, so that's it for Giardia lamblia. Now let's go to Entamoeba histolytica. Okay, so first thing that I want you guys to notice is the difference in appearance of the trophozoite of the trophozoite in Giardia lamblia and Entamoeba histolytica. So here in the Giardia lamblia, you had the trophozoite had 2 nuclei. Here it has 1 nucleus, and you might ask me, well, what are these little black dots? Well, these are ingested red blood cells. Okay, this is something very specific to Entamoeba histolytica. Their trophozoites ingest red blood cells. Sometimes you'll find them inside of the trophozoite. Okay, and this is an amoeba. So differently from the trophozoite of the Giardia lamblia, where that one was a flagellate, this one is an amoeba. So that means you see this little thing? This is the little pseudopod that I mentioned. So it has little foot-like projections, and that's how it's able to move around. Okay, so the life cycle again is direct. So a trophozoite, which has 1 nucleus, and the cyst has 4 nuclei. So this is important. The cyst of the Entamoeba histolytica has 4 nuclei, whereas the trophozoite has one nucleus. Okay, and again, as you can tell, you can differentiate it from the Giardia lamblia in that it's a little rounder. Okay, so the Giardia lamblia is a little more oval in shape. So the transmission is very similar. So again, cysts in contaminated water or anal-oral transmission, and that's because you're ingesting these cysts. Population, it's tropical countries and homosexual men, similarly to Giardia lamblia. Now, signs and symptoms, dysentery. So what does dysentery mean? Can somebody tell me?
Blood in the stool.
Yeah, blood in the stool or bloody diarrhea, anything like that. So that's how you define it. So if you see this, it's a very, very strong indicator of amoebiasis, which is, by the way, what the disease is called. So Entamoeba histolytica causes amoebiasis, and Giardia lamblia causes giardiasis. Okay, and right upper quadrant pain is another sign that you find in Entamoeba histolytica. Liver abscess. This is super important. So if there's two things that I want you guys to remember about the presentation of a patient with amoebiasis is the dysentery, which is the blood in the stool, and the liver abscess. Very important. Who can tell me what? Basically, there's a picture that's very. It's a classical picture of amoebiasis. It has to do with the liver abscess. So after,
because Entamoeba can also cause extra intestinal issues.
well, yes, that's true. But what's the picture? So there's a picture. They always show it when it comes to Entamoeba histolytica. And this picture, there's a name for this picture. Maybe I'm not being specific enough. It's the flask-shaped ulcer that I want you guys to focus on. So that's how it leaves the intestinal wall through this flask-shaped ulcer. Okay, we'll get to that in a second. Okay, so some extra information about the Entamoeba histolytica. Now, this part, the extra information part, not all of it. Like this is just some information that I really didn't know where to place. It doesn't really fit in anywhere. So it's just some things they should remember. So again, no animal reservoir for the Entamoeba histolytica. And then the cysts can differentiate into the trophocytes in the ileum, but they colonize the colon. Okay, they colonize the colon. And then boiling or filtering removes the cysts. So this is similarly to Giardia lamblia, except here we added boiling. So filtering both removes the cysts of both Entamoeba histolytica and Giardia lamblia. Okay.
So the route of administration and the basically there is a lot of similarities between like the ambiasis and the
Yes.
gambia, but the only difference is that one creates ulcerations and bloody diarrhea, another one doesn't.
Exactly.
Right?
Exactly.
And the morphological change.
Exactly. Exactly. That's it.
Mhm.
So in clinical presentation, most of the time, you're like in both cases, Entamoeba and giardiasis, you would get somebody who basically drank contaminated water or is a hiker or stuff like that. But the main difference would be in the clinical presentation and the morphology once you get a blood smear or once you get a histologic.
Yeah, but they also have I just want to ask you questions. Is there any difference between the life cycles, like the life cycle, the infective stage, for an example, or the diagnostic? So the infective stage here is basically cyst, just like the gambia.
Yeah.
Mhm.
Okay, so it says right here, right? So the cysts can also be ingested in amoebiasis, and that's also the infective stage. Okay, and as you can see here, the cysts, there's this little sign. This means that it's the infective stage and the diagnostic stage. And you can also find the trophozoites so it's very similar life cycle. So again, cysts ingested, trophozoites in the colon, but again, the difference is with Entamoeba, it migrates outside of the colon too. And then you have the trophozoites and the cysts passed in the feces, okay? And again, you can see the trophozoite here, it has the one nucleus and the pseudopod, which is why it's an amoeba. Okay, so again, the pathogenesis, so the cysts transmitted fecal orally, trophozoites invade the colonic epithelium, and this is important, secrete necrotic enzymes. That's what causes the flask-shaped ulcer. Okay, so basically, the difference is with Giardia, you'll basically have these trophozoites with the little suction discs, and they'll attach on the colon wall, and they'll cause malabsorption, all those things. With Entamoeba, not only will they attach, but they'll also secrete these enzymes that basically cause necrosis of the intestinal wall, and that's what causes this flask-shaped ulcer. Okay, and the systemic disease. So when I mentioned systemic, it means non-GI. Systemic means systemic all around the body. The systemic disease would be in the liver. Now, this is super important. So Entamoeba histolytica loves the liver. It loves to go to the liver. It loves to migrate to the liver and, infect the liver and all those types of things. So those are the main differences between Entamoeba and Giardia. Okay, and the diagnosis is similar, the cyst and the trophozoite and the enzyme immunoassay. Okay, you need to know what these cysts and these trophozoites look like. Trophozoites. Okay, so again, this is the case presentation for Entamoeba histolytica. You guys can see this is from ChatGPT. I'm not going to read all of it, but you guys can see a 10-day history of progressively worsening diarrhea and blood-streaked stools. Okay, returned from a trip in South Asia, consumed local foods and unfiltered water. Okay, you guys can see it. She's been experiencing weight loss, whatever. You guys get it? So the main thing you should be looking at is drinking unfiltered water, and then she gets blood-streaked stools. So this is amoebiasis. It causes bloody diarrhea, liver abscess. Okay, so again, that's those are the signs that we talked about. Right upper quadrant pain, and causes also flask-shaped ulcers in the colon. That's how it invades the epithelium. Does that make sense so far? Those are the two GI protozoa that you guys took.
Do they both have definitive host, or there is no host?
No, both of their hosts are the humans.
Human, so a definite host.
Right. Yeah.
And direct life cycle.
Direct life cycle. Again, the only time you guys should really be focused on the life cycles and whether this parasite has a direct one or an indirect one, are in the ones with indirect. Usually, if they ask you a question, they're going to ask you questions about the protozoa with indirect life cycle, and that's because you need to know what the vector is, right?
Yeah.
What type of animal, or what the definitive host is, and which one is the intermediate. Usually though, in questions, they'll mostly focus on the clinical presentations, okay, or the morphology. Okay. Now we're done with GI protozoa. I want to ask you guys a few questions. Not questions. I want you guys to test your knowledge by looking at some pictures and using some critical thinking. And then we're going to move on to our next chapter, inshallah. So here's the first question. Match the cyst with the trophozoite. So who can tell me?
2 with B, I think,
B.
and 1 with A.
Yes.
So, sorry, what was the answer? You said 2 with B? No, sorry.
Yeah.
2 with B and 1 with A?
Yes.
Yes.
Yeah.
Okay, perfect.
2 with B is gonna be the
Giardia.
Giardias.
Giardia.
1 with A is going to be amoeba.
Exactly, Entamoeba. And which one causes, without using names, just give me a number or a letter. Which one causes bloody diarrhea or blood streaks?
1A.
1A, which would be the
Entamoeba.
Exactly. Perfect. So when I get these questions for you guys, I'm going to use some of the times I'm going to be using different pictures. So you notice here the trophozoite here for the Entamoeba does not look like the trophozoite here, and that's because I picked a different pictures just to show you guys that these little dots are not the nuclei; these are the red blood cells. So this is what the nucleus would look like. Okay. Matter of fact, let me hold on, just to remove the ink annotations. Yeah. So this is what the nucleus would look like right here. You guys see it in the middle? Okay. And the other things are the red blood cells. So this is what the nucleus would look like in Entamoeba. Okay. Next question. This one's fairly simple.
Entamoeba.
Entamoeba, correct. Perfect. Okay, so GI protozoa are really easy. Okay, so you guys, inshallah, are all good with your GI protozoa. Let's move on to blood protozoa. Okay, Plasmodium. Now, Plasmodium is the big one. Okay, you guys are going to learn this again in your 3rd year, inshallah. I'm currently learning about Plasmodium again, but it basically causes malaria. This is super important. Now, the Plasmodium species, we're focusing on three specific different organisms within the Plasmodium species. They're vivax, ovale, malariae, 4, and falciparum. Which one causes the most serious disease? Falciparum, exactly. So falciparum would cause the most serious disease. The others would also cause malaria and disease of some kind. Okay, so now the life cycle here is indirect. This time, which one is the definitive host instead of it being the human? It's the Anopheles female mosquito. It has to be the female. This is what it looks like. So it's a mosquito. The species is called Anopheles or Anopheles, whatever you might want to say. So that's the definitive host. So if it's the definitive host, that's where the sexual reproduction will take place. Okay. So how is it transmitted? It's transmitted through sporozoites from the saliva of mosquito or a blood transfusion. Now the blood transfusion is very rare. More commonly, of course, you would see it from the saliva of the mosquito. So when a mosquito comes and it bites you, sometimes it may have, it might be infected with Plasmodium, and it may release these sporozoites inside of the saliva. Okay. So the word spore, I guess you guys could tell from the definition, from the word sporozoites. Basically, it's immobile at this stage. Sporozoites, as in sporozoans. Okay, you guys remember we talked about the movement of the protozoa and how we can classify them into sporozoans, flagellates, amoebas, and ciliates. So sporozoans, obviously, so in this case, the sporozoites would be immobile. Again, not that important, just something that you guys could, it's a way to help you remember what the movements sound like. Populations found in Africa, Latin America, and Asia. Again, not that important. Signs and symptoms, this is important. Anemia, splenomegaly, and cyclic fevers. What does that mean? A cyclic fever, what does that mean? Somebody tell me.
Fevers that comes and goes?
Fever that comes and goes, and it's cyclic. So it's basically every 3 days you would get a fever. Every 4 days you would get a spike in your blood, in your temperature, in your body temperature. Okay. In third year, you guys will learn more about why this happens. Actually, I guess in this block you'll also learn about why this happens. It's because, we'll get into it soon, inshallah. But you'll also learn about which specific one causes what type of cyclic fever. So sometimes you'll have a certain species of Plasmodium that causes quartan fever. That means every 4 days. Again, not that important. So extra information. So vivax and ovale can lay dormant and reactivate years later, causing disease. They basically, vivax and ovale have this different stage in their life cycle called hypnozoites. So I guess you guys can remember it because of hypnosis means basically, I guess when you think of somebody who's hypnotized or is undergoing hypnosis, then he might be asleep. So you might think of hypnozoites as these sort of dormant stages in the Plasmodium life cycle. And they only occur with vivax or ovale infections. Okay? And again, falciparum causes the most serious disease because it infects all stages of the red blood cells. We'll talk about that in a second, inshallah. So this is what the life cycle would look like, okay? It's a little big, but stay with me, inshallah, it's gonna make sense, okay? So first of all, we're gonna start from one. So the mosquito is gonna take a blood meal and it's gonna inject the sporozoites inside of the person, okay? First place that these sporozoites are gonna go is the liver. Once they go to the liver, they're going to basically invade the liver. They're gonna start going into liver cells, into the hepatocytes, and they're gonna form these things called schizons. Okay, so you find these inside of the liver, or you can find them inside of the red blood cells later on. But a schizon basically is a word for parasites, intracellular parasites that are multiplying and replicating inside of the cell. Okay, now this is exoerythrocytic cycle because it's taking place outside of the blood, outside of the bloodstream, outside of the blood system, and here where it would be taking place in the liver at this stage. Okay, so again, you have sporozoites going to the liver, forming schizons. Once these schizons rupture, they're going to release, it doesn't say this here, but they're going to release merozoites. Merozoites are going to enter the bloodstream, and then they're going to do the same thing. They're going to enter the red blood cells, and then they're going to form these trophozoites. Again, so this is similar to the trophozoites because at this stage, they're feeding. Okay, so they're feeding, so we call them trophozoites, and they're going to be inside of the red blood cells. Now, once we see this picture, so it looks like a ring inside of the red blood cells. This is called the ring stage, or at this point it would be an immature trophozoite. And this is the diagnostic stage. Okay, that means a lot of the time when you guys get a picture of Plasmodium, you're going to get a picture of this little ring-like structure inside of a red blood cell. That's how you know that this is the ring stage of Plasmodium. Okay, and then it's going to mature. It's going to form this mature trophozoite, and then again, it's going to form a schizon. That's because all of these trophozoites are multiplying, they're replicating inside of this red blood cell, and then it's going to rupture, releasing sporozoites. Okay. Again, it's going to rupture, and then it's going to repeat that cycle. Now, sometimes the trophozoites here can exit the stage, okay, and they can form gametocytes, and these gametocytes they can then exit the cells, and then they're going to get picked up again by the mosquito, and then they're going to undergo their sporogonic cycle, which is the sexual reproduction. Okay, not that important to remember. Just make sure you go through it really quickly. Know that this is what it looks like. These are what it's called, but we don't have time to, dissect all of the protozoans life cycle very in depth. So I want you guys to focus on the human stages. Okay, so again, sporozoites released into the human from a mosquito. They attack the liver. They form schizons. They release merozoites. It's going to come up soon, inshallah. Then they're going to enter the erythrocytic cycle. They're going to enter the bloodstream. They're going to start infecting red blood cells. They're going to form ring stage, which is the trophozoite. And then they're going to sometimes exit the cycle, form gametocytes, and then get picked up again by the female Anopheles mosquito.
Which can you show like which phase you were talking about that attacks the RBCs and start producing ring shape, which is the diagnostic stage?
They're called merozoites. It says it right here. Merozoites. Okay, it's right. Hold on one second, just wait for my Apple Pencil to connect. Hold on, I'll just zoom in. Right, so this schizon will basically rupture, and it's going to release these merozoites, these things right here. You guys see these things right here? They're going to infect the red blood cells, and they're going to form the trophozoites and the schizons again in the blood cell, in the blood cells, and it might exit the cycle and form gametocytes. Okay, so again, sporozoites to schizons, to merozoites, to trophozoites, and then sometimes it'll exit the cycle and form gametocytes, and that's when it'll get picked up again by the mosquito. So this is what an indirect life cycle looks like. Okay, so this is the life cycle. Now let's get into how the disease is formed. So the disease of malaria, it's basically just formed by the cycle of blood cell rupture, and again, the rupture of the red blood cells would cause the fever. So why is it a cyclic fever? That's because every single time these schizons rupture and they release these merozoites, it's going to basically cause inflammation, which will cause the fever. Okay, but it's only cyclic because again, the rest of the time, these parasites are inside of the red blood cells, so they're away from the systemic circulation. So they're sort of hidden in these red blood cells until it ruptures and it can form an inflammatory reaction and then cause the fever again. So that's why it's a cyclic fever. Does that make sense?
Yes.
Okay, perfect. So we said earlier that falciparum is the most serious disease. And why is that? That's because it affects the red blood cells of all ages. So you guys know we have your reticulocytes, which are your super young red blood cells. And then you have your old red blood cells that are about to die. They're about to be taken out by the reticuloendothelial system. So falciparum affects all of the RBCs, every single red blood cell, no matter what stage you're in. Okay, that's why it's the most serious disease. Now, vivax and ovale, it can affect only the younger RBCs, which are the reticulocytes, and the malariae affects the older red blood cells. That's why they're not as severe as the falciparum disease. Okay. All right. So again, the main clinical presentations of Plasmodium or malaria in general is anemia, cyclic fever, and sometimes a splenomegaly. And that's because the splenomegaly is basically sequestering all these infected red blood cells. But again, that's not that important to know. Okay, so how do you diagnose Plasmodium? Basically, you have your thin and thick blood smear. Okay, thin and thick blood smear. Why do we call it thin and thick blood smear? Can somebody tell me?
Because you're using okay, wait. Do you want to say it? There was a girl who wanted to say it.
It's
I
okay.
think yeah.
Okay, so the thick smear, basically you're taking the blood and you're basically using thick blood and you're removing the boundaries of RBCs. You're just seeing the nuclear informations of the Plasmodium without the boundaries of the RBCs. Meanwhile, in the thin smear, you're just seeing the boundaries of the RBCs.
RBCs. Exactly. Pretty much, yeah. So again, thin smear. A quicker way to say it would be in thin smear, you could see red blood cells, and thick smear, you can't see red blood cells. That's the main way to tell, and it's going to be the same picture. So who can tell me at this stage what stage are we in Plasmodium?
Ring stage.
Ring stage which would be the trophozoite. Okay, so again, just to recap the stages, you have the sporozoites, okay, and then you have the schizons, and then you have the merozoites, and then you would have the ring stage, and the mature trophozoite, and then the schizon again. and then sometimes you would get these little gametocytes. Okay, just to quickly recap. Now, you can also stain it using Giemsa stain, which you'll also see with Babesia, with the Babesia species. Just something to remember. And then there's also two ways to detect it using its basically molecular structure, and that's the rapid detection test. So all Plasmodium have this thing called the parasite lactate dehydrogenase, and Falciparum specifically has the histidine-rich protein 2, which that's what it stands for. So Plasmodium falciparum, histidine-rich Plasmodium or protein 2. So basically, you would get this little band, okay, and across this band you would get these little antibodies. Okay, you have these antibodies for different types of proteins all throughout this band. So the first strip or the first band that you would see is a control antibody. So this one's supposed to be always positive. Okay, and the second one is anti-malaria. So if it's anti-malaria, which one do you guys think it uses? What type of protein do you guys think? Like, what are the antibodies against? They're antibodies against what? If it's for all malaria. Okay, that's all right. So again, we have these three bands right here. I'm not sure why my pen is not working, but I'll just zoom in. We have these three bands right here. The first one is the control band. The second one is anti-malaria antibody. That means it affects, or sorry, it's antibodies against all types of Plasmodium species, whether it be malariae or falciparum or vivax or ovale. Okay, these are antibodies against parasite lactate dehydrogenase. Okay, and that's because obviously all of the Plasmodium species have this lactate dehydrogenase. And the third one is specific for falciparum. And why is that? That's because it contains, who can tell me? I just pointed it out, so it should be pretty simple.
Histidine.
Right.
Wait, histidine antibodies.
Right. Yeah. So histidine-rich protein 2. Okay. So these are antibodies against histidine-rich protein 2. So basically, in here, what these three bands are telling you, since they're all positive, this is a control, so this is supposed to be positive. This is telling you that this patient does have malaria or does have a subset of Plasmodium, and then this tells you that it's falciparum. So either at this stage, either it's mixed malaria, so it doesn't just have to be falciparum, or it's just falciparum. Okay, here it's telling you that it's non-falciparum malaria, so it is malaria, but it's not falciparum because it's the antibodies basically don't bind to the histidine-rich protein 2 of falciparum, so it's not positive. And here it's invalid. Why is that? Because the control is negative. Okay, when the control is supposed to be positive. So just something that you guys can help you understand better, because I know it too from last year. Sometimes you see these pictures and you're like, yeah, okay, sure, rapid detection test. And sometimes you might not even know what exactly it's supposed to be detecting. So if they ask about this in OSPE, inshallah, you guys will be all good. Okay, and these are some pictures. So this is the trophozoite. This is the ring stage. Okay, so this would be a thick stain. This will be the thin stain, the third one. And then this is a schizon. Again, is this schizon of a hepatocyte or a red blood cell?
Hepatocyte?
RBC. It's actually RBC. That's because obviously it'd be very difficult to visualize the schizon inside of the liver. And plus you could see these RBCs all around. So this is inside of the RBC, and these are the gametocytes of the Plasmodium, of falciparum specifically. Okay? All right. Perfect. So again, let's do the clinical presentation. So 27-year-old Ali, 3-day history of high fever, chills, and sweating. Episodes of fever spikes every 48 hours. So this is what? Cyclic fever, accompanied by severe headache, muscle aches, and joint pain. Okay, so some fatigue, dark colored urine. So the dark colored urine is telling you that this is hemolytic anemia. Not that important, but it's another sign. Mild jaundice, nausea, extreme fatigue after each fever episode. So extreme fatigue is telling you that this is anemia. Okay, so he recalls returning from a business trip to West Africa, and he missed his malaria prophylaxis medication. So this is malaria, obviously. And this is, again, a table from first aid. So falciparum, severe irregular fever pattern, parasitized RBCs, whatever. You guys get it, okay? So the transmission, again, is through the Anopheles mosquito. All right, Babesia. Now, this, a lot of the time, this is, again, another blood protozoa. A lot of the time, this is confused with malaria, and that's because it has a similar presentation and a similar morphology, specifically in one of the stages. Okay, but we're going to go through it pretty quickly. So it causes babesiosis. Okay, so bit of a tongue twister. It has an indirect life cycle with this tick, which is called Cestodes scapularis. Just remember the tick, which is the vector. The transmission is through tick bites. So if the transmission is through tick bites, what type of population would you guys see is infected?
Hikers.
Hikers, exactly. So hikers, they go to the forest. The classical presentation would be somebody who's wearing short socks. So they always advise that you wear long socks when you go hiking so that the ticks can't access your ankle or your foot or anything like that. Signs and symptoms, it causes anemia, fever, so similarly to malaria. And then some extra informations would be the Babesia divergence infection occurs only in post-splenectomy patients. And that's because Babesia, as you guys know, the spleen basically, it takes out infected RBCs or RBCs that are sort of, they're abnormal RBCs. So it clears them from the circulation. In post-splenectomy, you no longer have a spleen to clean up all of your blood. So you would get these infections much more often, specifically from divergence. Microbiology is the most common agent in non-splenectomized patients in the US. It's often misdiagnosed, and humans are dead-end hosts. So what does that mean if you're a dead-end host?
There's no.
You can't transmit to any other.
Exactly. So if it's a dead-end host, it's no longer transmitted to any other species, whether it be a human or any other thing. Okay? So I mentioned that it's an indirect host. So it's an indirect life cycle. So the two different species would be the mouse and the tick. And sometimes accidentally it can end up in a human. Okay? So this is how it happens. Again, the sporozoites are introduced into the host from this tick. It can go to the blood. So here, oppositely from Plasmodium, instead of going to the liver, it's going to skip the liver, go straight to the blood. And then it forms these trophozoites and the merozoites. And it could be transmitted human to human via blood transfusion. But again, when I say dead-end host, I mean naturally, there's no way for this parasite to go anywhere else. So once it's in the human, unless it's cleared out via medication or the spleen or anything like that, it's going to stay in the human. It's not going to go anywhere else. Okay? So the trophozoite and the merozoite. Okay, without even going to the next slide, who can tell me what this picture looks like? What's the name for this picture?
Cross something.
Maltese cross.
Maltese cross. Okay, so that's this is very specific to Babesia. Okay, so we guys see this? 99% of the time is going to be Babesia. Okay, so again, this is the life cycle. So the sporozoites from the tick, then the trophozoites that are diagnostic. So the sporozoites would be infected, the trophozoites would be the diagnostic, and then the merozoites which would form these Maltese cross. Diagnosis is similar. You have thin and thick blood smeared, stained with Gamsa stain, and it shows the Maltese cross. So this is the Maltese cross right here. You can see intra and extra erythrocytic forms, or you could test the serum for antibodies against Babesia. But mostly you're going to see this, so the thin and thick stains. And this is the presentation. So 65-year-old male, John, fever, and then so non-Hodgkin's, whatever. Where's the thing? Cross formation. There it is. You see it? Maltese cross formation. So, so you guys can see it has a very similar presentation to malaria, but a lot of the times they'll show you the picture, and that's how you'll know it's Babesia. What type of tick is it again? It's the Cestodes tick. Okay, and this is the first aid table. This is the disease. This is the vector. This is the diagnostic form, and this is the medication. You guys don't need to focus on the medication. Okay, moving on. Leishmania. Okay, so Leishmania, the different organisms we have in the Leishmania species are Donovani, Tropica, Mexicana, or this one I just remember as Brazil. So the Brasiliensis. And again, the type are flagellates. So these are flagellates. So they're masticophora. They cause leishmaniasis. Okay. Now, who can tell me before even look? You know what? I'm going to zoom in so you guys can't see the bottom. Who can tell me which one of these four species can cause visceral leishmaniasis?
Donovani.
Donovani. Okay, perfect. All right, so that's the most serious one, the most serious form of leishmaniasis. Okay, so the life cycle again is indirect. This time they're transmitted, instead of being through a tick, they're transmitted through the sandfly. Now, please remember what these pictures look like. Sometimes they'll get you in the exam, they'll bring just a picture of the vector, and they'll ask you to identify or to diagnose this patient. And you won't have any blood smears, you won't have any histology pictures, you won't see the actual parasite, all you'll see is the vector. So you have to know what they look like. So this is a sandfly. Okay, you guys can tell from the little hairs that it has all over its body. That's how you tell that it's a sandfly. It also looks golden, so you might associate that with sandfly because it's light brown. And it carries Leishmania. Okay, so again, indirect life cycle. The transmission is from promastigotes. So you guys remember when I told you that flagellates are also called mastigophora? So that's how you guys can remember that these are flagellates, because they're called mastigotes, promastigotes. Okay, from sandfly. I don't know why it says sand. It's supposed to say sandfly. Okay, so for signs and symptoms. Now, Donovani causes visceral leishmaniasis. Mexicana and tropica cause cutaneous, and Brazil causes mucocutaneous leishmaniasis. Okay, so the visceral leishmania affects the reticuloendothelial system. So what does that cause? It causes splenomegaly. It causes bone marrow depression and pancytopenia. So you guys know that your bone marrow is the site of all red blood cell formation and leukocyte and white blood cell formation. So if you have bone marrow depression, you're going to have pancytopenia, which is a decrease in all types of like blood, all types of blood. So either red blood cells or white blood cells. So that's pancytopenia. And you would have anemia, and you would have splenomegaly. So this is visceral leishmania. Okay. So if you guys see a picture of a child and he has a distended abdomen, okay, a distended abdomen basically, which would mean like sort of like a tummy, and they're telling you he was bitten by a sandfly, this is visceral leishmaniasis because it's going to cause the splenomegaly. And the splenomegaly is going to appear as a sort of bulge. So it's going to have some distension. Okay, this is the life cycle. So you have the sandfly, it's going to inject promastigotes into the skin. And then these promastigotes, they're going to be phagocytized, I guess, by macrophages. So once they're inside of the macrophages, they become amastigotes. So amastigotes, what does that say? What does the prefix A mean in mostly anything? A.
No.
No, exactly. So if it's an amastigote, it means it has no flagella. Okay, so amastigotes are the diagnostic version. Yeah, the diagnostic stage of leishmaniasis or leishmania. Okay, now after these amastigotes form in the macrophages, they're going to rupture, and then these amastigotes are going to go and they're going to multiply in cells of various tissues and affect other cells. So that's why you would get visceral leishmaniasis, okay, or mucocutaneous or cutaneous. I guess in cutaneous, it would stay in the skin. In mucocutaneous, it would affect the skin and also any other mucous membranes and stuff like that. And in visceral leishmaniasis, it would go to the reticuloendothelial system, which would be the spleen, the liver, the bone marrow, things like that. Okay, and then again, these amastigotes would basically, or sorry, the sandfly would then bite the human again, and it would sort of take or pick up these macrophages that are infected with amastigotes, and then another sexual reproduction cycle would happen in the sandfly. Okay, so promastigotes, then amastigotes, and then picked up by the sandfly again. Amastigotes are found in macrophages. Okay. All right. So again, this is the life cycle. We don't have to go over it again, but the diagnosis is through either tissue specimen, because as we said, these Leishmania parasites can go to various different tissues. So you can go to the bone marrow for visceral leishmaniasis. You can diagnose it by taking a biopsy or a specimen from the bone marrow. And for cutaneous or mucocutaneous, you can check the skin sores. They're going to have skin sores. Okay, or you can basically diagnose it through seeing the amastigotes in the mononuclear cells, the macrophages, or you can also see sometimes the promastigotes in the bloodstream. Okay, so these are what they look like. So these are the amastigotes. You guys can see, this is mononuclear. This is a macrophage. You guys can see by the single nucleus. And these little things inside are the parasites. They're the amastigotes, these little things. Okay, these are the promastigotes. Again, they're mastigotes because they have the flagella. Who can tell me what is the other parasite that we talked about that is also a flagellates?
The
Giardia lamblia.
yes.
Giardia lamblia, perfect. Okay, so it looks, you guys can tell that it looks a lot different. Okay, so these bodies are way more slender and way thinner than the ones with Giardia lamblia. That's how you tell the difference. Okay, so this is visceral leishmaniasis. This is what I was talking about. So in this case, you would have the splenomegaly. And then this is cutaneous leishmaniasis. Okay, it would cause a skin sore, basically because of necrosis around the bite sites. Okay, so these are the pictures that you need to know for leishmania. Again, you might get different pictures that look a little different in your exam. And I tried to include different pictures than the ones in your slides because it's really the best practice is to look at as many pictures as possible so that you can, you don't just rely on your knowledge or your memory of just that one picture in your slides. You guys can sort of build on your knowledge and you can look at different types of pictures so you guys can see all the different presentations, okay? So these are what the promastigotes look like. This is what the amastigotes look like. This is the clinical presentation. Slowly enlarging painless ulcer on the left forearm. Okay, so this is cutaneous leishmaniasis. Okay, mild itching around the lesion, but no significant pain, fever, or systemic symptoms. Okay, so this is cutaneous. It stays in the skin. Okay, she returned from a trip in the Middle East, and she recalls being bitten by several sandflies. So this is classically presenting a case of leishmaniasis, cutaneous leishmaniasis. Okay, since there is no anemia, there's no splenomegaly, there are no hematological symptoms. So this is how you can tell that this is cutaneous leishmania. Okay, and again, macrophages containing amastigotes, that's the diagnostic stage. Sandfly is the vector. Okay, now Trypanosoma, brucei gambiense, and rhodesiense. Okay, these cause the African sleeping sickness. So the west one, there's a West African sleeping sickness. This is caused by TB gambiense or gambiense, and the east one's is caused by rhodesiense. Okay, what's the vector? The vector is the tsetse fly. Tsetse fly. This is what it looks like, the tsetse fly. Okay, and what type of stage is the infective stage? They're the metacyclic trypomastigotes. Mastigotes again because they're flagellates. They're mastigophora. And trypo, you can just remember trypanosoma, trypomastigotes from the tsetse fly. Okay, so TT. Okay, so signs and symptoms: somnolence and coma. This is important. This is why they call it the West African or the African sleeping sickness, and lymphadenopathy. Why does it cause lymphadenopathy? That's because once you're infected with these trypomastigotes, they're going to go into your lymphatic drainage and they're going to move up into your brain, and then they're going to cause CNS symptoms, and most severely, they're going to basically make you fall into a coma. So the pathogenesis again through lymph node spread, and it's CNS involvement due to demyelinating encephalitis. Do you guys know what encephalitis means, by the way? I know you guys you didn't take neuro yet.
Brain, inflammation of something.
Exactly. It's the inflammation of the brain tissue, like the brain tissue itself. So you guys have meningitis, which is the inflammation of the meninges, which is the surrounding of the brain. And then you have encephalitis, which is the basically inflammation of the brain tissue itself. So it causes demyelinating encephalitis, and that's how it causes the coma. Okay, so this is the life cycle for the Trypanosoma brucei gambiense. This is important that you guys don't just remember Trypanosoma. You have to remember brucei because there's another Trypanosoma we're going to talk about later on. Cruzi causes a different type of disease. So brucei, basically this tsetse fly is going to inject the metacyclic trypomastigotes. This is what they look like. This is important. Guys, by the way, another thing. The trypomastic, you know what, we'll get to it later. It's not that important. Just remind me later on to talk about the trypomastigotes. Okay, Yasser, remind me later on to talk about trypomastigotes. Once we get to cruzi, remind me to talk about trypomastigotes.
Sure.
طيب. So you get these metacyclic trypomastigotes. They're going to transform into the bloodstream trypomastigotes, which are carried to other sites. Then they're going to multiply by binary fission, whatever. Then they're going to move to the lymph nodes. Okay, so again, they're going to multiply by binary fissions in various blood fluids. So move through the lymph node, and then they might move up to the CNS, to the brain, and that's how they cause the coma and the somnolence and all those things. Okay. All right, and then again, these trypomastigotes, the same ones, they're going to be picked up by the tsetse fly again. and then they're going to form procyclic and whatever and epimastigotes and all those things. Okay, guys. By the way, the only reason I'm skipping the tsetse fly is because it's difficult. There's not a lot of time to go into the entire life cycle. That's not to say that you guys shouldn't know this too. You guys should know the stages that take place in the tsetse fly. Okay, but I'm just reviewing it very quickly so you guys know at least the most high yield stuff, which is the human stages or the mammalian stage. Okay, so again, the infective stage would be the metacyclic trypomastigotes, as you can see here, the infective stage. And the diagnostic stage would be the circulating trypomastigotes in the blood. This is during the acute phase. Okay. All right. So again, metacyclic trypomastigotes and then trypomastigotes again, and then they're taken up by the tsetse fly again. So the vector is the tsetse fly. It's important to remember. Diagnosis through ELISA for the IgM antibodies, blood microscopy, and you're going to look for these trypomastigotes in the blood. So this is what it looks like. Okay. This is what the skin sore would look like in Trypanosoma. I don't think, if I recall, I don't think they got us this picture, or they even showed us what the skin sore would look like in Trypanosoma. So I can't tell you whether or not they're going to bring it this year for your guys' exam, but it's really important that you guys know what these trypomastigotes look like. So you guys can tell they have these little flagella that almost looks like an extension of the membrane. Okay, it doesn't really look like a flagellate; it just looks like an extension, but it's still a flagella. So these are your trypomastigotes. Okay. All right. So this is the presentation. Again, so Maria, extreme daytime sleepiness, so somnolence, daytime sleepiness, worsening confusion and bizarre behavior. So these are your CNS symptoms. They're going to be caused by your encephalitis or the demyelinating encephalitis. Okay, she initially had intermittent fevers, headaches, and body aches that gradually subsided, but her neurological symptoms have worsened. Now, who can tell me why did the fevers and the headaches and the body aches subside, but the neurological symptoms got worse?
I guess because it has already entered the brain.
Exactly. So at this point, these trypomastigotes, they're leaving the circulation. They're going into the lymph drainage or lymph nodes or lymph vessels, lymphatic vessels, and they're moving up to the brain. So they're being taken away from the systemic circulation. So they're causing less of that fever and more of those neurological symptoms. Okay. So it causes, and again, she was bitten by several flies. That's how you know that it's Trypanosoma brucei. Okay, so African sleeping sickness, enlarged lymph nodes, recurring fever due to antigenic variation, not that important, somnolence and coma. Okay, this is a painful bite. One thing to remember is that it's a painful bite, the tsetse fly bite. Okay, all right, we're done with blood protozoa. Okay, let's get some questions going. So who can tell me which one is Plasmodium and at which stage?
Plasmodium is the third one. It's the gametocyte stage.
Perfect. Thank you, Yasser. Now, somebody else, who can tell me what the fourth one is? This one. Span.
Leishmania,
Leishmania. What stage?
trophozoites. I don't know.
Close.
Trichomonas.
Nope. The fourth one, not the first one, guys.
Promastigotes.
Promastigotes. Perfect. What about the first one?
Trichomastigotes.
Okay, perfect. And one last person who can tell me what the second one is. This is a trick because this is not a blood parasite.
Trophozoite of entamoeba.
Exactly.
Histology.
Histolytica. Exactly. Great job, guys. So these are trypomastigotes from brucei. This is the trophozoite from the entamoeba. These are the gametocytes. So this is the answer. And these are the promastigotes from Leishmania. Okay? Perfect. Okay. Who can tell me what the diagnosis is? These three pictures.
Leishmania.
Leishmania. What type?
This is cutaneous.
Cutaneous Leishmania. Perfect. And somebody else, who can tell me what the infective stage of Leishmania is? Anyone?
Promastigotes.
Promastigotes. Perfect. Perfect. Now, somebody else who can tell me what this stage is. This one, this third picture. What's the stage?
Amastigote.
Yeah, amastigotes.
Amastigotes inside of the macrophages. Okay, perfect. And finally, this vector is called the sandfly. So this is Leishmania or cutaneous Leishmania specifically. Okay. All right. Moving on to tissue protozoa. So we talked about African sleeping sickness, which were the Trypanosoma brucei, gambiense, or rhodesiense. Now we get into the Trypanosoma cruzi. Okay. What's the disease? Chagas disease. Okay. Or Chagas myocarditis, because it can affect the heart. Now, this is, yeah. This is the one parasite that you'll learn about that can infect or that can affect the heart. So it's really important to remember if somebody has cardiovascular symptoms, palpitations, whatever, and again, presenting with the other presentations of Trypanosoma cruzi, then a lot of the time it's going to be Chagas, which is cruzi. Okay, so again, indirect life cycle. It's caused or it's transmitted through the reduvid bug, which is the kissing bug. Okay, you guys can remember because it looks red. You guys can see these little red things on it. That's how you remember it. So the first three letters are red of this word, reduvid. So it's a red bug, kissing bug. And again, the infective stage are the trypomastigotes from the feces of the reduvid bug. So this is different. This is how they might trick you guys in the exam, okay? Because in Plasmodium, for example, the transmission is through the bite or the saliva of the mosquito bite. Okay, so the mosquito is going to come, it's going to bite you, and it's going to release these sporozoites in the saliva. Okay, but here in the kissing bug, basically it's going to take a bite, and then it's going to actually defecate, and these trypomastigotes are in the feces of this kissing bug. So that's how you get the transmission. Okay, I forgot to include the population, but it's really not that important. Signs and symptoms. You have acute symptoms, which are your Riemannia's sign and the Shigoma, which we'll look at in a second. Riemannia is basically it's unilateral periorbital swelling, so it's swelling around the eye, and the Shigoma is basically just the ulcer or the skin nodule, the ulcer where the bite actually took place. And then you have dilated cardiomyopathy. This is another sign and symptom of Trypanosoma cruzi. So DCM stands for dilated cardiomyopathy. And you may have megacolon. Okay, but the main things to remember are the pictures. We're going to look at the pictures in a second, and the dilated cardiomyopathy. Okay, extra information. Many organs can be affected, but the most common are the myocardial cells, which is again the heart, glial cells, and the reticular endothelial system. Okay, so this is the life cycle. You get these bugs, the kissing bug, that can release these trypomastigotes or the metacyclic trypomastigotes into the blood. And then instead of the amastigotes this time being inside of macrophages, the amastigotes are going to go into random cells, random tissues. Okay, these tissues most commonly would be the myocardial tissues, or like mentioned, the reticular endothelial tissues. Okay. So the intracellular amastigotes will then transform back into the trypomastigotes and then burst out of the cell and enter the bloodstream. And this is the diagnostic stage because once they're in the bloodstream, you can more easily detect them. And then sometimes these trypomastigotes will go and they'll infect other places. So sometimes it's just the cycle of the amastigotes, burrowing away in a random tissue, in a random organ, and then they'll pop out as trypomastigotes, and then they'll go back into another area in the body. Okay, until again the same bug comes back and it ingests these trypomastigotes in the blood, and then the whole cycle repeats over and over and over again. Okay, so if I ask you guys what's the infective stage of Trypanosoma or cruzi?
Metacyclic trypomastigotes.
Exactly, and the diagnostic would be the
trypomastigotes.
right, or actually also
or the amastigotes.
The amastigotes. Okay, you could see both. You could diagnose it through both. Okay, perfect. So the metacyclic trypomastigotes to the amastigotes to the trypomastigotes again, and then back, taken back by the kissing bug. Okay, so Diagnosis is made through a smear, so you can see the trypomastogotes. You can also take a biopsy of the tissue, and that's because obviously, if you're going to visualize the amastogotes that are buried away in random tissue, it's going to be a biopsy. It's not going to be just a blood smear. That's where you're going to see the amastogotes. This is a more chronic case, obviously, because it's going to take time for these mastogotes, for these trypomastogotes to go into the tissues and infect other organs. Or serology, again, you can test for the antibodies. Okay. These are the few pictures. So this is the Romania sign. This is the unilateral periorbital swelling. Shagoma. This is where the bite happened. The trypomastogotes. Yeah, right. That's what I was going to say. Remember when Yasser, I asked you earlier to remind me? The trypomastogotes look the same in cruzi and in brucei gambiense. Okay? So if you see this picture, don't immediately go to one or the other. Don't immediately go to cruzi or brucei. You have to learn actually more about the clinical presentation. Okay? So if you see this picture and they tell you that he's having
CNS symptoms.
CNS symptoms, or even somnolence or daytime sleepiness, then it's brucei. If they're having myocarditis or dilated cardiomyopathy or palpitations like heart symptoms, then it's cruzi. Okay, and this is what the amastogote look like inside of the myocardium. Okay, so this is what they look like. Okay, so these pictures, I want you guys to remember them. For Trypanosoma cruzi, it causes Chagas disease. I'm not sure if I mentioned that. Did I mention that this is Chagas disease, by the way?
Yeah, you did.
Okay, great. So Chagas disease caused by cruzi. Okay, this is the presentation again. So we're gonna go through it quick. Shortness of breath that worsens when lying flat. Ooh, this is important. This is a little bit too advanced for you guys. Shortness of breath that worsens when lying flat. This is actually a acute symptom of heart failure. Okay, and that's because it's too much to go into detail, but just know that. You guys actually, you don't need to know that. This is just a clinical.
I guess it's just because his heart is failing to pump.
Exactly. So the blood will then move back into the lungs, and that's going to cause the shortness of breath. But it's not that important to know. Swelling of the legs is also the same thing. So this is a symptom of heart failure. Okay, grew up in a rural area where Chagas is endemic. He was bitten by kissing bugs as a child. Okay, whatever. And then his cardiovascular symptoms began gradually and have become severe over the past few months. And he has shortness of breath and frequent fainting. So this is Chagas disease. Okay, so what can you see? You can see dilated cardiomyopathy, megacolon, megaesophagus, unilateral periorbital swelling, which is Romania sign. And then again, you diagnose it through the trypomastogotes in the blood smear. Okay, perfect. Let's move on. This is Toxoplasma. Now, I like to think of Toxoplasma as the cat disease. So that's how you guys probably think about it too. So this is the cat disease. Okay. Toxoplasmosis, that's the disease. It's an obligate intracellular protozoa. And actually, the cool thing about Toxoplasma, it's actually one of the most successful parasites. That's because it's very, very common to see, but it does rely on your cell-mediated immunity. So basically, a lot of people get infected with Toxoplasma gondii, but our immunity, specifically the cell-mediated immunity, it's very successful in fighting back against this parasite. So in a lot of the cases, the patients are going to be asymptomatic, okay? But in cases where, for example, either you're immunocompromised from AIDS or in any other situation where your immunity might be a little weaker, you might start getting these symptoms of Toxoplasma, okay? So how are you transmitted, or how is this parasite transmitted? Either you ingest oocytes from cat feces. So here you'll see basically cat owners who spend a lot of time with their cats. They're cleaning out the cat litter, for example. They accidentally ingest some of these oocysts from the cat feces, or tissue cysts from uncooked meats. It can also be transplacental. Okay, this is really, really important. Toxoplasma gondii can also be a congenital disease, and that's if the mother was pregnant, the pregnant woman, if she contracts a infection of Toxoplasma during her pregnancy. This is important, during, not before, during her pregnancy, then it can cause congenital toxoplasmosis, and that's because this parasite can travel through the placenta and it can infect the child. Okay, so what are the population? Cat owners and the immunocompromised, and that's because it's a very successful parasite. It just relies on the or basically our body relies on the cell-mediated immunity to get rid of, or basically to prevent this infection or the symptoms from taking place. So some extra information. So congenital infection only happens when the mother is infected during the pregnancy from the tachyzoites. We'll get into the life cycle soon. And the cell-mediated immunity plays a major role in defense against this parasite. So what are the symptoms? You have CNS symptoms, because the tissue cysts can also be in the brain. And the tissue cysts can also be in muscle. So you might get also muscular symptoms. So how does this happen? Basically, from these cysts, you're going to get tachyzoites. So the tachyzoites, they're basically rapidly dividing parasites, and that's why we call them tachy for fast, tachyzoites. And then they can basically go into the tissue and they can form these cysts. And inside of these cysts, you can find bradyzoites. And that's because brady for slow, because they're slowly multiplying, slowly replicating inside of these tissue cysts. Okay?
Is it because the immune system just tries to stop them?
Exactly. Perfect. So that's why you would get these. That's why our immunity is so helpful in protecting against this infection. That's because it keeps these parasites inside of these cysts, okay, and prevents them from exiting. But again, sometimes especially when these cysts go to the brain, they'll still cause some symptoms, okay, despite us having a successful cell-mediated immunity, okay. So basically, this is a bit of a complicated life cycle, but we'll try to dissect it as much as we can. So basically, what you can have are these unsporulated oocysts inside of the cat's feces, okay? From there, either a bunch of different things can happen. Either you can have intermediate hosts that ingest these oocysts, so that would be your cattle and your pigs and stuff like that. And then they can have these, they can be infected with these tissue cysts, and then the humans eat uncooked meats. So for example, these oocysts, you have a cow who's going to eat who's going to ingest these oocysts from a cat's feces, and then they're going to develop tissue cysts. And then humans are going to eat the uncooked meat of that cow. Then they're going to be infected with the Toxoplasma parasite, or Toxoplasma gondii. Okay? Or it can skip that intermediate host and it can go straight into the human. And that happens basically with cat owners. So the one with cat owners happens usually when humans become infected when they consume the food or water contaminated with cat feces, or by handling the litter box or stuff like that. And that's how they can get infected. Or they can ingest uncooked meat that already contained the tissue cysts. Okay, does that make sense?
Yes.
Is that good? Okay. Now, once these humans ingest these cysts, basically they're going to transform to tachyzoites, as mentioned here. Again, this is it says that it's taking place inside of these intermediate hosts, but it's the same cycle in the humans. It can transform into tachyzoites, and then these tachyzoites can localize in neural and muscle tissue and develop into tissue cysts, bradyzoites. Okay? So that's the cause for infection, or that's the pathogenesis. Okay? So you guys can read this on your own. It's very important that you guys go through the life cycle. Again, different ways of transmission can be eating undercooked meat of animals harboring the tissue cysts, so they're already infected with the parasite, and then you eat their meat. That's how you get the infection. Or by just straight up consuming food or water that's contaminated with the cat feces, or blood transfusion, which is very rare again, or congenital toxoplasmosis from a maternal infection during pregnancy. During pregnancy is the main point. Cannot happen before pregnancy. Okay? And that's because your body is already sensitized to this parasite, so it's going to be very able to fight against it later on. So for example, if the mother gets an infection prior to her pregnancy, and then she gets the same infection again, so the same parasite toxoplasmosis again during her pregnancy, it's not going to cause congenital toxoplasmosis. That's because the body is already we already have a set immunity against this parasite at that point. Okay, so how do you diagnose these patients? Either through tissue biopsy, so you can see the cysts, most commonly in the brain, so that's where you see the infection mostly, or the liver, or the lungs, or the eyes. Histological section, so you can see the bradyzoites or the tachyzoites. Through IgM, so that's how you diagnose congenital infections, is through IgM. so immunoglobulin M antibodies, or through amniotic fluid PCR. So both of these last ways are used to diagnose congenital toxoplasmosis. Okay. Again, this is the case presentation. 28-year-old pregnant woman, Sarah, in her second trimester, is brought to the emergency department by her husband after experiencing several days of worsening headache, confusion, and new onset seizures. These are your CNS symptoms. Okay, where's the cat? I'm sure we'll find a cat. Yep, avid gardener and cares for her pet cats. Okay, regularly changing its litter box. Immediately, that's toxoplasmosis. And she had no prior neurological issues, so now you're ruling out any other neural diseases. So what's the disease? Toxoplasmosis, reactivation in AIDS. Congenital is whatever you guys can see, and it's a brain abscess. Okay, so in AIDS patient, you guys can see a brain abscess, and that's because it infects the brain. Transmission is through cysts, or cysts in meat, or oocysts in cat feces. Okay, and the diagnosis is made through tachyzoids or PCR of amniotic fluid. Okay, all right. Now your Trichomonas vaginalis. This is a very, very easy protozoa. Okay, we're gonna move through it very quickly, inshallah. It's only sexually transmitted, so it doesn't live on its own. It's very reliant. So it's an obligate. It's an obligate parasite because it has to live. It rarely survives outside of the human. So it's transmitted sexually. It cannot form cysts, and you diagnose it through motile trophozoites. So that's pretty much the only thing you guys need to know about Trichomonas. Okay, so this is what they look like. Okay, they have 4 anterior flagella, and they're motile trophozoites. They're flagellates again, and the life cycle is only through sexual intercourse. Okay, so the infective and the diagnostic stage are the trophozoites. Okay, it's pretty much the only thing you guys have to know for Trichomonas. Pretty easy. Okay, acanthamoeba. Okay, now we're starting to get into our free-living amoebas. Okay, now the 2 ones that I want you guys to know are the Culbertsoni and the Castellani acanthamoebas, and they can cause 3 different diseases. Okay, 3 different diseases acanthamoeba can cause, and that depends on the transmission. Okay, so first one it can cause is the keratitis. So where do you guys see, what's the population that's mostly affected by the acanthamoeba keratitis?
People with contact lenses.
With contact lenses, perfectly. Perfect. Sorry, I don't know why I said perfectly. Or you can get the granulomatous amoebic encephalitis. Do you guys know what granulomatous means?
You can see granulomas.
You can see granulomas. Okay, granulomas are these basically multinucleated giant cells, exactly, surrounding an area either of necrosis or is just sequestering these parasites. So that's what you see. Or you can see a disseminated infection, which is just a systemic infection. It's just affecting the body all throughout. Okay, so what's the class of parasites? So these are free-living amoebas. And again, since they're amoebas, they have pseudopods. That's the way they move. Okay, so the transmission is entry through eyes or contact lenses, inhalation, or through wounds and cuts. Okay, so your classic presentation. Sorry, 1 second. Your classic presentation are people who go swimming in freshwater sources and lakes and rivers, and then all of a sudden they develop visual disturbances and stuff like that, and they happen to also be wearing contact lenses during their time in the water. Then this is pretty much acanthamoeba. Okay, so the signs and symptoms you have for keratitis, you can get red eye, blurry vision, eye pain, photosensitivity, so just eye symptoms in general. And for granulomatous amoebic encephalitis, you can get CNS symptoms. Okay, so seizures, confusion, somnolence, all that stuff. Okay, this is the life cycle. So again, you have these cysts inside of the water, and you can also, so as you guys can tell, it can be transmitted through various means. So the first way is through the eye, and that's what causes the keratitis, or through the nose, or through ulcerated or broken skin. So through the nose or through the nasal passages to the lower respiratory tract, this is going to cause your granulomatous amoebic encephalitis or disseminated disease. Okay, but the one that you have to remember mostly is through the eye one. That's the one that's going to cause the keratitis. Again, you find these cysts in freshwater sources, and since they're free living, that means they can basically transform into trophozoites and cysts on their own. Okay, and they only accidentally end up in humans once they are transmitted through the eye or through the nasal passages or anything like that. Okay, so how do you make your diagnosis? You can make it either through a corneal scrape or a culture. This is for keratitis, or for granulomas, or for GAE, for granulomatous amoebic encephalitis, through CSF microscopy. Okay? All right. Okay, so a 32-year-old female presents to the ophthalmology clinic with a 2-week history of worsening eye pain, redness, and blurred vision in her right eye. Okay? She reports that the symptoms began after a recent trip to a lake where she swam while wearing contact lenses. Immediately. I don't even have to read anything else. So she has eye symptoms. She took a recent trip and she swam while wearing contact lenses. And she has photophobia and all those things. Immediately, it's acanthamoeba. Okay. Do we have any questions? I know that this is, it's a bit much to do in a short period of time. So do I have any questions about any of the protozoas that I've covered?
Can I ask about, like, when we say trophozoite, when we say bromastigoids, so the names, like, this is confusing, man.
I'm sorry?
So when do we say trophozoites?
Right.
Or bromastigoids, amastigoids? So is it like the names specific to maybe the mortality or something?
Well, no, because you're going to see these names in very different parasites, very different, and many different protozoa. Okay. But for example, for mastigotes or promastigotes, amastigotes, you know that these are flagellates. So these are parasites that have the flagella, and that's why we call them promastigotes or even trypomastigotes. Okay. For trophozoites, basically the name means that they're at a stage where they're now feeding. So because the word tropho means like sustenance or nutrition. So they're at a stage where they're feeding and where they're, seeking out food. But genuinely, I guess you just have to memorize it for all the parasites, unfortunately, because each parasite has a different name for all the cycles, and you have to know what these look like. But for some, it's very easy. For example, for these, you can tell that they have a flagella, so that's telling you that it might be like a mastigote, or sorry, they're mastigophora. They have flagella. Okay, so I guess it's just something that you have to memorize. Okay.
Okay.
Metacycline, trypomastigotes, and all those things. Any other questions so far?
Thank you.
No problem. Anyone else? All good? Okay.
All good.
Let's move on. So Naegleria fowleri. This is another free-living amoeba, similar presentation or similar transmission as acanthamoeba. Okay, but it causes a much different disease, much more serious here in Naegleria fowleri. So this causes brain-eating amoeba. Okay, it causes it's called the brain-eating amoeba, and it causes primary amoebic meningoencephalitis. So for that big of a word, you have to know that this is a serious disease. So meningoencephalitis means that it's an inflammatory reaction of the meninges and the actual brain matter. So again, an abbreviation would be PAM. So that's what it causes. They're thermophilic, free-living amoeba. What does that mean? They're thermophilic. That means they love warm water sources. Okay, so that's your natural streams, stuff like that. Hot tubs, right? That's how they're transmitted. That's where they live. They love the warm water. Okay, and how are they transmitted? They're transmitted through the cribiform plate. You guys know where the cribiform plate, by the way, is? I know that you didn't take neuro.
Cribiform plate, where it's in the head and neck region.
It's basically in your nose. It's inside of your nose. It basically separates the inside of your skull from your nasal passage. Okay, that's actually where the olfactory goes.
Like down the one of the gland, the one.
No gland.
Pituitary gland. Is it down the pituitary gland?
Yes, 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 yes. Yes,
Yeah.
it's close to the pituitary gland. It's close to the pituitary gland, yeah. It's in the ethmoid. It's not that important. But anyways, basically the transmission of these Naegleria fowleri are through the cribiform plates, and then they travel up the olfactory nerves. So the olfactory nerves are your nerves that are in charge of your smell. Okay, so your smelling sensation, it travels up these nerves, and then it affects your brain. Okay, now, if we're saying that it has to be transmitted through the nose or through the cribiform plate, what do I, as a person, have to do in order to be infected by this parasite? So let's say I'm swimming right now, and I'm keeping my head above water. What do I have to do in order to be infected by this parasite?
Go under the water.
Go under the water, exactly. So a lot of the time, the presentation would be somebody who's swimming, and then they dunk their head in the water, or a warm source of water. And that's how you get Naegleria fowleri. So if you guys check your slides, there's a sign in certain places in the world where it's known, like it's a very common parasite. Some water sources will have signs put up like, please avoid dunking your head in the water, please avoid diving, because you don't want your head to go under the water, because then you're giving yourself a risk of a Naegleria fowleri infection. Okay. So again, since it's a brain-eating amoeba, we can expect CNS symptoms. So that's your stiff neck, because stiff neck is a sign of meningitis. So stiff neck, you would see that here. Painful headache, very, very painful headache. Nausea, disorientation, confusion, coma. So your CNS symptoms again. Okay, additional information. So it only exists in 3 forms: the trophozoite, which is the infective stage, the cyst, and the flagellates. Okay, so this is the trophozoite. This is the flagellate form, and this is the cyst. Okay. So this is the life cycle. So it's water-related activities such as swimming, underwater, diving, or other water sports can cause water entering into the nose, and then the amoeba can penetrate the nasal mucosa, can travel up to the brains, cause PAM. How do you diagnose it? You can diagnose it with by visualizing the trophozoites in the CSF and brain tissue, and occasionally you'll find the flagellated form. Okay, and again, since it's a free-living amoeba, it can basically transform into the different forms on its own without the need of a vector, right? So it's free living. So from the cyst to the trophozoite to the flagellated form, and so on, and then the flagellated form can actually infect. Okay, or the trophozoite. Sorry, either this or the flagellated form can infect the human being. Okay, so how do you diagnose it? Again, CSF, Naegleria fowleri, DNA in the CSF, so this is through molecular assay or histochemical staining. Okay? So again, main thing you have to remember about Naegleria fowleri is warm water sources, dunking your head underwater, and CNS symptoms. Okay? So this is the case presentation. Swimming in freshwater lake. Initially only mild headaches, and then rapidly deteriorated, high fever and altered mental status, photophobia, and he is an active swimmer and enjoys spending time in freshwater lakes. Okay, so that's telling you that this is a Naegleria fowleri infection. What is the cause? A rapidly fatal meningitis, swimming in warm fresh water. So this is the key word here, warm. Enters the CNS through olfactory nerve. Okay. All right, let's move on. So we're done with the tissue protozoa. We're actually making good time. It's only been about an hour and a half, which is pretty good. So what's the diagnosis? Who can tell me?
Toxoplasma.
Toxoplasma. And now somebody else, give me another method of transmission.
Transplacental.
Sorry?
Transplacental.
Transplacental. Okay, one more.
Blood transfusion.
Okay, one more.
Eating the oocyst or the cyst.
Exactly. So eating uncooked meats that harbor the tissue cysts of Toxoplasma gondii. Okay. And again, the last one, which is already here, is through cat feces. Okay. What is this? What is this stage called?
Is it a tachyzoid?
Tachyzoid. Exactly.
Yes.
And what about this?
The tissue cysts.
Brachiozoid.
Brachiozoids.
Exactly. Brachiozoids. Perfect. Perfect. Great job, guys. Okay. Here's the next question. This is a little bit of a, you have to think a little bit. So which one of these is most likely to cause cardiomyopathy?
It was Trypanosoma cruzi, right?
Is it the second one?
Yep, perfect.
Second one.
The second one. So these are, what stage is this? Who can tell me what stage is this?
Trypomastigote.
Perfect.
Yes.
Trypomastigotes. Now, somebody else who can tell me what the, you know what? It's easy enough. I want one person to tell me the rest of these three. So the first one, second one, and third one, what disease they are, or sorry, what organism it is, and the stage that we're at.
The first one is Trichomonas.
Mhm.
They flagellate. They flagellate.
Yep.
The second one we already said it.
Say it again.
Third, it's Trypomastigote of Trypanosoma cruzi.
Oh, sorry, the second one. Sorry, I thought you were talking about the third one. Sorry, yeah.
No. The third one is Trypomastigote of Leishmania. No, Promastigote of Leishmania.
Promastigotes. Yep.
And the last one is Babesia.
Right.
And you can see the merozoites.
Merozoite and the trophozoite, both.
Yeah.
Perfect. Great job, guys. Great.
The third one is Leishmania.
Yes,
And
Leishmania.
the first one what?
Trichomonas vaginalis. So we're going to go back to it. This is the first one. So this is the picture, Trichomonas vaginalis. Actually, Yasser, these are the trophozoites. Okay?
Tamam.
Okay. It's only have a trophozoites, right?
Yes. Motile trophozoites, obviously. Okay. But again, they are flagellates. So, anyways, we're done with protozoa. I'm pretty sure that's all of your protozoa, right? Does anyone have any question about any protozoa we took so far?
All clear for me.
All clear?
Yeah.
Good stuff?
Yeah.
Alhamdulillah. Okay, helminths. This is the second half. The helminths, we can split them into, basically, first of all, helminths are parasitic worms, okay? So, since they're parasitic worms, we can classify them based on their shape. So either they're flatworms, which are the platyhelminths, or they're nematodes, which are the roundworms, okay? In your slides, it also says nematohelminths, nemahelminths. It's the same thing as nematodes, okay? These are your roundworms. Now, platyhelminths, which are your flatworms, can also then be further classified into trematodes, which are your flukes, and your cestodes, which are the tapeworms, okay? So nematodes, just to describe their shape, first of all, they're fully smooth. They're fully smooth. They don't have any segment. They're not segmented. So imagine an earthworm. You guys know the little earthworms. You know, you see them in the soil a lot of the times. The pink ones. Yeah.
Yes.
Those ones are segmented. If you take an earthworm and you just take away all of those little segments, that's basically what a nematode would look like. So it's a completely round worm, no segments, and none of that whatsoever. You can also then further classify. There's a few more differences between nematodes and platyhelminths. So nematodes, they're roundworms, as we mentioned. They have male and female worms. So they have, it can be either male or female. Okay. And they have a presence of a complete alimentary canal. Okay. An alimentary canal is basically another word for a digestive tract. The different wording is that because a digestive tract is specific to humans and other mammals that have the organs and everything like that. Alimentary canal just basically means where the food goes in and where the food comes out. Okay, so for flatworms, you have again, they're platyhelminths. They usually exist as hermaphrodites. So this is different from nematodes because in nematodes we have the male worms and female worms. In flatworms, most of the times they're hermaphrodites. So that means they have the organs, the male sexual organs, and they have the female sexual organs. Okay, and the difference again is that a lot of the times, most of these worms have an incomplete or completely absent alimentary canal. Okay, so it's just not present. This is what some of the flatworms would look like. I guess this is more technically a trematode, which is a fluke, but it's also a flatworm. And these are what roundworms look like, nematodes. Okay, let's get to it. The first one we're going to talk about is Ascaris lumbricoides. So Ascaris lumbricoides is a gastrointestinal roundworm. So obviously, since it's a GI roundworm, it's going to cause GI symptoms. It's going to cause ascariasis. Okay. Now, just like protozoa, we have an infective stage and a diagnostic stage. Now, the infective stage is an embryonated egg with second stage larva. Okay, so you can have an embryonated egg, but the larva inside is still not fully formed. That's not the infective stage. The infective stage is specifically an embryonated egg with second stage larva inside. And the diagnostic, again, is the adult form that's found in the intestines. Okay, now, one thing that's very important to know, or very important to look out for when you're studying this lecture, studying helminths, is you have to know what the cysts look like. Okay, the cysts specifically, because a lot of the times with roundworms, specifically with the nematodes, you can't really differentiate between the adult form of one worm or another. Okay, and that's because, like I mentioned, they're all roundworms. They all look very similar, but the eggs look very different. Okay, so similarly to protozoa, sometimes they'll get you a picture of an egg and they'll ask you what species is this from. You'll have to know just based on the shape of the egg. Okay, now the difficult part comes in which, like, sometimes some of the different worms have different stages of the eggs. So the eggs can look differently depending on whether they're fertilized or unfertilized. So in this case, with Ascaris, you guys can tell the unfertilized Ascaris egg, it looks more oval, and the shell is very rough. It has a very irregular shape. It looks almost kind of bumpy. So this is an unfertilized Ascaris egg. Now, once it becomes fertilized, you can start to see it becomes a little bit more round, so it's not as oval. Okay, and you can start to see that the shell smoothens out a little bit. Okay, it still has these little bumps, but it smoothens out a little bit. Okay, and then you can tell inside there's these little tiny circles. Those are the nuclei that are, or sorry, not the nuclei, but the cells that are reproducing inside of this little shell. Okay, so that's how you tell the difference between different stages of the Ascaris egg. Okay, so how are they transmitted? They're transmitted through soil, where the eggs are ingested. Okay, so where do you find this? You find this in gardeners, people who work a lot with the soil, stuff like that. That's how you ingest these eggs. Okay. Now, what type of disease can they cause? They can cause lung inflammation and Loeffler syndrome. So Loeffler syndrome is pulmonary eosinophilia. If you guys remember from HLS in your first year, you guys know eosinophils are responsible for attacking parasites. So let's say hypothetically, if a worm were to make its way up to your lungs, then the eosinophils, then you'll start to see eosinophilia inside of the lungs. So that specific finding is called Loeffler syndrome. So that's what it can cause. It can also cause abdominal symptoms. Okay, so through the life cycle, we'll know why it affects the lungs as well as the abdomen. Okay, so this is the life cycle. So ingestion of embryonated eggs again. Now, this you guys have to focus with me a little bit. So after the eggs are basically swallowed, they make their way down into the GI tract, where they can then migrate into the lungs. Okay, this is important. Migrate into the lungs, and then they can make their way up the bronchial tree, up the trachea, and then they can be swallowed again. So they'll go to the GI tract, they'll make their way to the lungs, and then they'll get swallowed again, and they'll finish their maturation inside of the intestinal tract. Okay, and then later on, and then obviously they can, you can pass the eggs of these adult worms in the stool, and that's how it's retransmitted. Okay, so again, ingestion of L3 larva. I'm sorry, did I mention L2 back here? Sorry, it's L3. Okay, level 3. And then the hatched larva enters the portal circulation through the enteric mucosa. So again, you're going to ingest these eggs. They're going to go down into your GI tract. And then the hatched larvae are going to enter the portal circulation through the enteric mucosa. So they're going to invade your mucosa. And then it's going to migrate to the lungs. It's going to be re-swallowed. And then it's going to finally finish its maturation inside of the intestines. And they're going to pass off these eggs in the feces. Okay? So that's your Ascaris. So once it's in the lungs, that's when it'll cause the Loeffler syndrome and the lung irritation and the coughing and all those things. Okay, and then once it's back in the GI tract, that's where it's going to cause the abdominal symptoms. Okay, does that make sense?
Yeah.
All right, perfect. And these are what the eggs look like. So you can tell as it becomes more fertilized, it starts to become more round, and it loses that rough shell. And yeah, that's how you can tell what stage it's at. So these are what the the different eggs look like. Again, this is unfertilized, a scarce egg. This is fertilized, and this is fertilized, a scarce egg with the larva inside. Okay, and then this is an adult worm seen on ultrasound. So this is the worm, as you guys can tell, seen on ultrasound. Okay, again, you have to be able to differentiate the different types of eggs, like the scarce eggs from different types of eggs. Okay. All right. Now this is a presentation. 6-year-old girl, Emily, is brought to the pediatric clinic by her mother with complaints of abdominal pain, poor appetite, nausea and vomiting, persistent cough, and episodes of wheezing over the past few weeks, which they initially thought was due to seasonal allergies. Okay, so she was experiencing a persistent cough, but now she's experiencing more abdominal pain. So what is that telling you? Ascaris. And why is that? Who can remind me? So why was she experiencing pulmonary symptoms a few weeks back, and now she's experiencing abdominal?
Because the worm was in the lung and then migrated to the intestine, so that's why.
Yes. I wouldn't use the word migrated because the migration
it would
is
be
from
coughed up.
It would be coughed up and then re-swallowed, basically. Yeah. So again, it's first in the GI tract, and then it's going to migrate to the lungs, and then from the lungs it's going to be coughed up and then swallowed back again and back into the GI tract. Okay. All right. And again, this is the table. You guys can read it on your own. Now, Trichiura. Okay. Now this one has a very, very characteristic shape of the egg. It's very obvious. Once you see this egg, you'll know that it's Trichiurus. So it's just something to look out for. This is another name for the Trichiurus worm is whipworm. So this is whipworm. It causes trichiuriasis. Second, drop my pen. Sorry, guys. Okay. So the infective stage are, again, similarly to Ascaris, the embryonated eggs. The diagnostic is the unfertilized eggs found in the species or the mature worms found in endoscopy. Similar transmission, so it's soil transmitted. The eggs are ingested. And the disease, this is important, loose stools, rectal prolapse, this is really important, and anemia. Why is it causing anemia?
Anemia because it's like taking the nutrients that the human is gonna eat, gonna consume.
Not
Feeding
exactly.
Blood?
Sorry?
Feeding on the blood?
Sorry, what was it? I didn't hear you.
Feeding on the blood?
No, not exactly that either. Basically, once it sticks to one of the things that Trichiurus can do, that a whipworm can do, is it can attach to your gut mucosa. Once it does that, it causes bleeding, and this blood loss would then cause anemia. Okay? You'll find this somewhere else. Okay? So this is what the eggs look like. This is very, you guys see this plug right here? This is very characteristic.
Bipolar plug.
Exactly, the bipolar plug. It's very characteristic of Trichiuria. Okay, again, you can see it. You can see it back here in the life cycle. This is what they look like. All right. This is the adult worm found in the colon. You guys can see it's wrapped up in the colon. That's because it's attached to the mucosal wall. And this is rectal prolapse. You guys know what rectal prolapse means?
Yeah, it's basically when the rectum like just is protruding through the anal canal.
Exactly. Pretty much. And that's because what this worm can do is that it can burrow its way into it can, like I mentioned, it's going to stick to the wall. And once it's sticking to the wall, it can sort of make the last part of basically the rectum, it can make it lose its support. And because of that, it's going to prolapse outside of the anus. Okay? It's going to weaken the epithelium and the elastic support of the rectum. Okay? All right. So this is the case. We're going to go through it really quickly. Rectal bleeding, because that's our first sign. You know what? How about this? Why doesn't let's have somebody else read this for me and point out some of the key symptoms.
Can I read?
Yeah, sure.
7-year-old boy Liam is brought to the pediatric clinic by his mother with complaints of recurrent abdominal pain, diarrhea, and recent episodes of rectal bleeding.
Okay, so you tell me and I'll circle.
All right. His mother also reports that Liam has been experiencing a sensation of something coming out during bowel movements. Circle something coming out. And she noticed protruding pinkish mass from his rectum after he strains. That as well, protruding pinkish mass. However, the past few weeks, Liam has been more fatigued, has lost weight, and has difficulty concentrating in school. Has lost weight.
Great, it's a good catch.
The family recently moved to a rural area with limited sanitation facilities. I mean, that could also be a sign as well.
It could be, but let's read a little bit ahead.
Okay.
For importance.
And Liam frequently plays outdoors, often in direct contact with soil. That's one of them.
Yep.
Liam is typically healthy with no significant past medical history. His immunizations are up to date. His mother mentions that their diet includes locally grown produce, which is sometimes eaten unwashed. She notes finding small amounts of blood in his stool, that as well.
Similar to the rectal bleeding, yeah.
And he has been more irritable and less active than usual. Recently, Liam has developed tenesmus, which is basically rectal prolapse.
Exactly. You guys don't need to know that word.
Hmm?
You guys don't need to know that word, tenesmus.
Feeling the urge to defecate even when there is little stool, that as well, which is basically evident of rectal prolapse.
Exactly. Perfect. Yeah, and again, episodes of rectal prolapse become more frequent, especially when he strains. Okay, so all of that's pointing to trichuris or whipworm infection. Okay. All right, let's move on. Enterobius vermicularis. Okay, these are known as pinworms. Okay, most commonly they affect children. This is very important, guys. It's really important that you know the most common population affected, the epidemiology. Okay, a lot of the times, when they ask you guys questions, they're going to get you the most commonly affected population. So if a parasite is more commonly to affect the elderly, they're going to ask you about an elderly patient. If they're more commonly associated with children, they're going to ask about a child. So just know that they're most commonly they affect children and people from tropical climates. So the infective stage are again the embryonated eggs. The diagnostic, this is really important. They are eggs in the perianal folds, which are prepared through the Scotch tape preparation. So that's how you diagnose Enterobius vermicularis or enterobiasis. Okay. Why is that? Before we even move on, who can tell me why we find eggs in the perianal folds? Something about the life cycle of this worm.
It's because the worm lay their eggs at the perianal area, so then that would cause itching. So like once you do Scotch tape, you see the worms and the eggs.
Exactly. Perfect. And again, the transmission is fecal oral. It can also be, this is so important, guys. I really want to highlight this. This is so important. It can also be airborne and inhaled. Okay. Little story time. In our POD final, they actually got us a question about Enterobius vermicularis. And obviously, when you get a question about Enterobius vermicularis, what do you expect? You expect to see a child who was scratching around his anal area, right? And that's how he gets transmitted the disease. In this case, it was actually, if I remember correctly, it was inhaled through the bed sheets. And nobody knew that this was Enterobius, and that's because everybody focused on it being transmitted fecal orally. Okay, but we noticed later on that in the slides, in very small writing, it said that it can also be inhaled and airborne. So don't remember that it's mostly fecal oral transmission, but it can also be airborne and inhaled. Okay, remember that. And what's the disease that causes pruritus, which is itching, and irritation around the perianal area due to migration of gravid females? So, can you tell me what gravid means?
The meaning of gravid.
Sorry?
Wait, so you're asking for the meaning of gravid?
Yep, meaning of gravid.
I guess it's basically young or something.
Not exactly.
The gravid problasts, you mean, right?
Yeah, pregnant. That's what the word means. Gravid females or pregnants. Right? Okay. This is what the Enterobius vermicularis worms look like. So you guys notice they have a transparent shell, first of all. They're convex on one side and they're flattened on the other side. Okay. Very classical, very specific picture for Enterobius eggs. Okay. So again, flat on one side, convex on the other side. All right. This is the life cycle again. So first of all, you find these gravid females migrating to the perianal region at night. So the classical presentation would be somebody who experienced a lot of pruritus at night. And that's because that's when they're coming out to the perianal area to lay their eggs. Okay. And then in the morning, you would get some itching around that area. A child would scratch it, and then they would accidentally ingest those embryonated eggs. And then the larva would hatch in the small intestine. And this is what the worms look like. Okay. So eggs are deposited in the perianal folds, self-infection by scratching the area and then transferring to the mouth. The larvae hatch and mature in the colon, and the lifespan is 2 months. Okay. The gravid females migrate nocturnally and deposit eggs outside the anus. Okay. So that explains some of the signs and symptoms. Okay. So this is what it looks like. Again, we know what the eggs look like. It's flattened on one side and convex on the other side. And this is what the worm looks like. Okay. All right, so this is a case presentation. Let's get somebody else, not Yasser, because mashallah.
I can do it. But wait, I have a question first.
Yeah.
So like basically there was something about like children that are mistaken to have ADHD. Which one was that?
Mistaken to have ADHD.
Yeah.
To be honest
I
with you,
think it was Enterobius. I think it was Enterobius. It's like suddenly the child is hyperactive.
okay.
Okay.
All right, yeah. To be honest with you, I'm not sure. That's the first time I'm hearing of this. Must be a pretty rare
Yeah, I don't know where I saw it.
clinical symptom. No worries. Do you want to read the case presentation?
Yeah, sure. So a 5-year-old girl, Sophie, is brought to the pediatric clinic by her mother due to persistent itching around her anal area. So itching would be part of it, like
Pen is
around
not
her
working.
anal.
I'll circle it later. The pen's not working right now.
Okay, no, that's fine. Particularly at night, her mother reports that Sophie's been waking up multiple times during the night and complaining of itchiness and discomfort, which has led to disrupted sleep and increased irritability. So I think that would be like part of it also. Family recently returned from a vacation where Sophie shared a room with her siblings, who have also been experiencing similar symptoms. So probably shared a room because of the bedsheet thing.
Yep.
Her mother has noticed Sophie scratching the affected area frequently, especially in the evenings. Sophie is generally healthy with no past medical issues and is up to date with vaccinations. She is an active child and attends preschool regularly. Doesn't have any pets at home and practices good hygiene. Her mother reports Sophie has no recent fever, abdominal pain, loss of appetite, and seems more tired and irritable lately due to lack of sleep. Also, I forgot to say that probably her age.
Yeah, exactly. Glad you caught that. I was about to mention that actually. Yep, her age.
Yeah.
Okay, perfect. Thank you so much. So yeah, again, this is Enterobius vermicularis, pinworms, anal pruritus, worse at night, visualized via tape tests for the eggs. Okay, most common in children aged 5 to 10, fecal oral transmission. Okay, all right. Okay, so hookworm infection. 2 specific worms for this, Ankylostoma duodenale and Necator americanus. Okay, so these are both hookworm infections. They most commonly affect poor individuals in tropical areas. Okay, why do they affect poor individuals in tropic areas? What is it about poor individuals specifically?
Feet and
Barefoot, exactly. So poor individuals in tropical areas, usually they walk around barefoot. They can't afford shoes. And these hookworms, basically, they're most commonly transmitted through the feet. Okay, so the infective and diagnostic forms, so the filariform larvae penetrate through the skin via proteolytic enzymes. Okay, so they release these little proteolytic enzymes and they can break through the skin and then they can go into the skin. So you can see here, that's a visualization of the worms inside of the skin. Not much of a bit of a disgusting picture, but it's okay. And the diagnostic form are eggs passed through stool. So similarly to all the others, transmission again is through skin penetration, and the disease, it can be iron deficiency anemia due to blood loss. Okay, this is similarly to the trichuris infection in that it causes anemia. This is causing iron deficiency anemia also due to the blood loss, and pulmonary symptoms due to larva migration. Okay, so this is similar presentation to trichuris. Okay, so the filariform larva. By the way, guys, it's important that you remember that word filariform larva. It's important for hookworms. Okay, and this is different to all the other or most of the other helminths because the infective form is not a cyst. The infective form is already like a larva. It's already, you know what I mean? It's definitely not an egg. So it's the filariform larva that's able to penetrate through the skin. Okay, once it goes in there, it's going to exit the circulation in the lungs, and then again, similarly to trichuris, it's going to be coughed up and then swallowed back again. Okay, I'm not sure if that was actually trichuris or another one, but again, it's coughed up and then swallowed again. Okay, and then you find these eggs in the feces. Okay, these eggs are very, they have a very specific appearance, and it looks like a bunch of circles on top of one another. Okay, once it looks like a bunch of circles on top of one another, that's how you know that it's a hookworm infection. Okay, and the infective stage again is the filariform larva and not the egg. All right, and the diagnostic again would be the egg. If that makes sense. Okay, so it's going to attach to the intestinal wall. It's going to cause blood loss, which then causes the iron deficiency anemia. Okay, so this is what the hookworms would look like on the first picture here. Okay, this is the hookworm egg. 2 pictures of the hookworm egg, just in case you guys don't get the full idea from one of the pictures. And then this is the site of penetration. You guys can see this little thing right here. That's the filariform larva. That's the hookworm worm, I guess. Okay, any questions about the hookworms?
The one that go to the lung, it's also Ascariasis lumbricoides.
Yeah, Ascaris lumbricoides, right? That's the one. Okay, perfect. So this is the presentation. I'm just going to read this very quickly. So Miguel, worsening fatigue, weakness, and lightheadedness. He's been feeling exhausted even after mild exertion, and recently noticed a persistent craving for ice. Now, this is a little bit too advanced for you guys, but these actually are symptoms of iron deficiency anemia. Okay, so the persistent craving for ice, exhausted after mild exertion, shortness of breath, and palpitations, these are anemia. Itchy red rash on his feet. Now, this is the first thing that's making me think for a hookworm infection, which began shortly after working barefoot on a construction site in a rural area. Okay, denies recent travel, but notes frequent exposure to soil during work. Stepping on damp, muddy soil, which led to a persistent itchy rash on his feet. Okay, so it's going to cause, again, that's telling you that this is a hookworm infection. Causes microcytic anemia by sucking blood from the intestinal wall. And it causes cutaneous larva migrans, which is pruritic serpiginous rash. That's where the infection site would be. Okay. All right. Moving on to Onchocerca volvulus. I'm pretty sure this is the last of our nematodes, and then the rest we have the platyhelminths, which are the flatworms. So inshallah, we're almost done, guys. Okay. So Onchocerca volvulus is going to cause African river blind. You know what? How about this? Since this is an interactive session, I'm going to have one person tell me everything they can about Onchocerca volvulus.
All
Who
right,
can tell me?
so
Yeah.
basically the mode of transmission is by the Plasmodium fly, or the black fly, female black fly.
Mm-hmm.
And it's also known as the African river blindness عشان it can cause blindness.
Exactly. Mm-hmm.
Its infective form is the L3 larvae.
Okay.
and then it will then once they reproduce, the female form will release the microfilariae, and then they move around the body, and then especially they go to the eye.
Exactly.
And then the black fly comes for a meal, and then it becomes the L3 larva through its life cycle. L1 larvae, but then L3 larvae.
Exactly. Perfect. Inshallah. So yeah, he's pretty much said all of it. So the infective stage, like he mentioned, is L3 larva entering through the black fly bite wound. So the vector would be, again, transmission would be through the female black fly. I'm not sure if you guys have another name for it, but black fly is the one that you guys should remember. Okay, so the diagnostic form would be the microfilariae found in the skin and lymphatics. Okay, in the skin and the lymphatics. And again, most commonly affects African tropical countries, causes blindness and skin nodules. So this is an example of a patient with river blindness. So this is the life cycle again. The black fly would come, it would release these L3 larvae, okay? And then these L3 larvae would sort of find their way into the subcutaneous tissues, and then where they would mature into adults. And then these adults would produce microfilariae, which then go and they also burrow in tissues all throughout the body, and most commonly in the eye, okay? And then again, the black fly is going to come and it's going to ingest the microfilariae, and it's going to restart the cycle. So how do you diagnose it? You diagnose it through a skin snip. This is important, skin snip, because it's going to show microfilariae. Okay, so the microfilariae are in your skin subcutaneously, and once you take a little biopsy of the skin or skin snip, you're going to find the microfilariae. Okay, so these are a few pictures. This is the black fly. This is the skin nodules that you can see in river blindness or an onchocerca infection. This is the river blindness, and this is the adult worm. Okay, for Onchocerca. Okay, so pretty easy protozoa. I think we're done the nematodes after this. Quickly to read this, Samuel presents to the dermatology clinic with persistent itching and skin changes, skin thickening in areas of depigmentation, and he also noticed a gradual decrease in vision, and he mentions that he lives in a rural area near a river, and he works as a fisherman. And he recalls frequently being bitten by black flies, but thought little of it until these symptoms developed. Okay, so again, black skin nodules, river blindness from the black fly. Okay, let's go into some questions. So, who can answer this? Which of these are transmitted through skin penetration?
First one.
The first one.
First one. Okay, and who can tell me what the rest of them are? First of all, what the organism is, and who can tell me what the rest of them are?
The second one, I think, is Ascaris.
Okay.
And it's transmitted via, you can cough it up and then you swallow it.
Okay. Transmission would actually be through the eggs, because in transmission,
basically,
yeah,
Oral.
fecal oral. Good.
okay. And then we have the Enterobius.
Vermicularis.
Yeah. And it's I think fecal. Wait, hold on. Hold on.
You're right.
Eggs. Yeah, the eggs.
You're right. It's fecal oral. It can
Yeah,
also
fecal
be-
oral, and also inhalation.
Yeah. And
And
then
then the last one is Trichoria.
exactly. Perfect. So the first one, the answer to this would be the first one, which are the Necator americanus, which is the hookworm. That's how it's transmitted. Ascaris, again, Enterobius, and Trichuris. Okay. Do you guys see it now? How you get, how you start finding the similarities between different images, and how you can use this knowledge to then go back to your slides and look at the pictures that they use. Because most likely the pictures that are going to show up in your exams are the pictures that they use in your slides, okay? This is just to show you guys other appearances and to be able to get you guys to recognize what they all look like in different images, okay? Now, who can tell me which organism has this life cycle? And what is the most common age group? This is a really easy one. Let me zoom in so you guys can see it clear.
Children,
what's
especially
the
in
disease?
daycare centers.
Okay, so around ages 5 to 10. What's the
أيوة.
disease? What's the organism?
This is Enterobius.
Yeah,
Enterobius. Exactly. Enterobius vermicularis. Great job. Okay, last section, cestodes. So cestodes are a subclassification of flatworms, and basically they're tapeworms. That's what we call them. So cestodes are tapeworms. So I think the only two that we have in here are Taenia and Echinococcus, but we'll get to Echinococcus later. Okay, now for cestodes, we have the Taenia species. Okay, first of all, I know you guys studied this already. We're gonna first talk about the Taenia species as a whole, and we're gonna talk about Taeniasis. The cysticercosis, we'll talk about it later on. Okay, so for Taenia species, we have the Taenia solium and the Taenia saginata. The Taenia solium is called the pork tapeworm, and the Taenia saginata is called the beef tapeworm. And why are they called pork tapeworm and Taenia and beef tapeworm? Well, that's because Taenia solium, you get a Taenia solium infection by ingesting raw pork that has cysticerca. Now, this is similar to the Toxoplasma gondii transmission by eating raw meats that have tissue cysts. This is similar. So by eating raw pork, it has these little cysticercae, which are also cysts, inside of this raw meat, and that's how you actually develop Taeniasis. Or you can eat raw beef, and that's how you develop Taenia saginata. So remember, solium for pork, saginata is beef. Okay, so the infective stage is obviously ingesting the cysticercae in raw meats, and the diagnostic stage would be the gravid proglottids or eggs and feces. So the gravid proglottids, by the way, they're the little sections of the tapeworm. Okay, so the gravid proglottids is a certain section where inside of the section it's pregnant, I guess would be a good way to describe it. Or you can find the eggs and the feces. So what's the disease? It can cause abdominal pain, diarrhea, and loss of appetite. So it's a gastrointestinal symptoms. Okay, this is the life cycle. Again, this is Taeniasis, not cysticercosis. Okay, now onchospheres develop into cysticercae in the muscle. This is by eating, for example, like if a pig were to eat or ingest the eggs of Taenia solium, then they would develop these cysts, the cysticercae in their muscle. Now, when humans eat that pig's raw meat, they can also accidentally ingest some of these cysts, and then these cysts can then develop and mature in their intestines into the tapeworms, which are Taenia saginata and Taenia solium. Taenia solium for pork and Taenia saginata for beef. Okay, and again, then they would pass off these eggs in the feces or the gravid proglottids in the feces, and then it would be passed on into the environment. Okay, makes sense. So this one's a very simple disease. It's just you're eating raw meats. This raw meat has cysticercae. These cysticercae are going to hatch. They're going to develop into mature worms in your intestinal tract. Okay. So again, this is the life cycle. I'm not going to read it again, but the diagnosis is made through characteristics eggs and stool or proglottids or gravid proglottids. Okay. This is what the Taenia species looks like. By the way, it's very difficult. It's almost impossible to differentiate Taenia solium from Taenia saginata using the eggs. Okay. Sometimes you could tell using the proglottids, but I don't think they'll ask you that much detail. And sometimes you're also able to tell through the adult worm heads. But this is what the Taenia species looks like. Eggs, you won't be able to know. Okay, so this is the Taenia species in general. This is what it can cause. So either Taenia solium or Taenia saginata can cause Taeniasis. Now, Taenia solium can also, or actually first let's talk about the case presentation. Abdominal discomfort, intermittent diarrhea, and recent weight loss. What else? Sensation of fullness and occasional cramps. And he frequently consumes undercooked beef as he enjoys rare steaks. Okay, so he recalls feeling something moving in his abdomen at times, but attributed it to digestion. So this is Taenia solium or Taenia saginata. Okay, so focus on this one right here. Okay, ignore this for now. Focus on this. So intestinal tapeworm, ingestion of larvae, insisted in undercooked pork. Okay, So that means larvae. These larvae are in cysts, which is the cysticerci, in undercooked pork. Pork for solium, beef for saginata. They can both cause the same disease. Now, Taenia solium can also cause cysticercosis. So what does that mean? That means that ingesting the eggs of Taenia solium can cause cysticercosis. What happens if you ingest the eggs of Taenia saginata? Do you also get cysticercosis?
No.
No. Perfect. So cysticercosis is only caused by the pork tapeworm eggs specifically. So how is it transmitted? By ingesting an embryonated eggs. And how do you diagnose it? Through the characteristic eggs and proglottids in the feces. Okay. And what sort of diseases can it cause? It can cause seizures, and that's because it can manifest in the brain. It can cause eye damage. It can cause muscle damage. All of these are because these cysts are going to different various parts of the body. Okay, most commonly brain, muscles, and eyes. Okay, so this is what the eggs look like. Again, it looks the same as this. Actually, it's the same picture. And this is what the head of the Taenia solium looks like. Okay, you can tell it looks. I think this is Taenia solium. This one right here is Taenia solium. Okay, there's another picture later on that'll show you what they both look like. Inshallah. Okay, so again, this is the life cycle for cysticercosis. So you're going to get these eggs in the feces of other, or for example, eggs. Like the Taenia solium eggs from either from pigs or from other humans, and then you're going to accidentally ingest these eggs, and then these eggs basically they're going to hatch, and once they hatch, they're going to be these oncospheres, and it's going to develop into these cysticerci, these cysts that can develop in various organs, and most commonly in the subcutaneous tissues, in the brain and the eyes. Okay, so how do you diagnose it? You diagnose it either through stool, where you can see the characteristic eggs and proglottids, and you can see the adult worms sometimes in the stool, or through the blood, through ELISA, or imaging studies, so you can see the neurocysticercosis in the brain. Sometimes you can also see calcified lesions all throughout the body. Okay, so this is what it looks like. Okay, you guys see, I'm going to zoom in on this picture right here. You guys can see this is an X-ray. You see these little nodules, these little things right here. All of these are calcified lesions. This is cysticercosis. Okay, this is what a Taenia solium proglottids looks like. Okay, and this is also neurocysticercosis. You guys can see these little dots in the brain. These are all parasitic cysts. Okay, and this is again the Taenia solium head. All right, all good so far?
How can we differentiate between teniasis and cysticercosis?
Great question. So you can differentiate it through different means. You can differentiate it based on clinical presentation. You can differentiate it based on history, whether that person is like how they got infected, or you can, clinical presentation and history. Basically, clinical presentation or history. So for clinical presentation, if the patient is showing up and they have symptoms that are not GI or that are different from GI, sorry, what just happened? Can you guys still see my screen?
Yes.
Yeah.
Anyways, so if the patient is presenting with symptoms that are not GI, for example, CNS symptoms, just anything that's not GI, then that's probably pointing to the fact that it's not teniasis. Or if the patient did not recently eat any raw pork or raw meat. Now, if they ate raw pork or raw meat, immediately this is teniasis. This is not cysticercosis. But if, for example, they're same presentation as before, so they're in the soil or whatever, or they're a farmer or anything like that, and they accidentally ingest the eggs of Taenia solium, then it would be cysticercosis. Okay? Does that make sense? So teniasis is only going to have, you guys can tell, intestinal tapeworm is only going to have like intestinal symptoms. Okay, and they're also going to mention, like for sure, 100% of the time when you get a question about teniasis, they're going to mention something about raw meats. You know, this person loves to eat raw meat, or he enjoys raw steak, or something about pork, eating raw pork, then this is probably teniasis. Cysticercosis would be more, extra gastro. It wouldn't really be gastrointestinal as much as the other symptoms. Okay, but here we'll look at the clinical presentation. Now we'll be able to tell. So Maria presents with a first-time seizure. Immediately, this is telling you, okay, it's not GI. Reports that she had been experiencing intermittent headaches and dizziness over the past few weeks, which they initially attributed to stress and lack of sleep, visual disturbances, and mild confusion. No previous history of seizures. Okay, recently visited family in a rural area of Latin America where sanitation is limited. While there, she ate local pork dishes on several occasions. She had no known allergies and does not take any regular medication. Now, in this case, I think either ChatGPT made a little mistake here with the pork dishes, because this is, this would be, I guess this is more pointing towards tenaces, which is the intestinal or gastrointestinal side of things. But I guess it can also happen with ingestion of food that's contaminated with human feces. So in this case, you could say that, for example, unwashed vegetables, something like that, soil, any vegetables that might have remnants of human feces, it might have these eggs, and that's what's causing the cysticercosis. So here, in this one, ignore the pork dishes. Okay, this is a little misleading. It's going to point more towards tenaces, when in cysticercosis, it's going to be the eggs that are ingested, and not. Does that make sense?
Yes.
Yeah.
Okay. All right. And then we're going to go to Echinococcus granulosus. So I like to remember this is the dog one. So we had the cat protozoa, which was Toxoplasma gondii. Now we have the Echinococcus granulosus, which is the dog one. Okay. So it causes echinococcosis. Okay, and then it's an indirect life cycle again, where dogs are the definitive hosts and sheep or goats are the intermediate. So what does that make the humans in this case? If dogs are the definitive hosts, sorry?
Accidental
Hosts, exactly, perfect. So in this case, the humans would be accidental hosts. The infective stage again would be the embryonated eggs in the dog feces, and the diagnostic form would be the hydatid cysts in the liver or brain or other various tissues in the body. Okay, so that's the cause for disease in humans, is the hydatid cysts. Okay, now depending on where these cysts are in the body, is going to manifest as different presentations. So if these cysts migrate to the liver, then you're going to be experiencing some jaundice, some abdominal distension, maybe some hepatomegaly, something like that. Abdominal cysts are going to cause discomfort and abdominal symptoms. Brain cysts are going to cause epilepsy and other CNS symptoms. Okay. Now, I bolded liver cysts. That's because it's the most common area of infection. So, Echinococcus, most commonly, it's going to affect the liver. Okay, and the brain and the abdomen to a lesser degree, but most commonly, it's going to affect the liver. Okay. Okay. Now, this is not that high yield, but you should know that Echinococcus granulosus, it causes a unilocular hydatid cyst, while multilocularis causes multilocular hydatid cyst. Okay, and multilocular or unilocular basically means within the cyst itself, there's like different tiny little chambers. Okay, it's going to appear as multiple cysts. That's multilocular. And unilocular hydatid cyst is going to just look like one cyst. Okay, this is what the worm would look like, the cestode. This is actually Echinococcus granulosus. It's known as one of the shortest tapeworm. That's because, as you guys can tell, it only has a head and then 3 proglottids. Okay, so it's very, very short. This is a very typical picture for Echinococcus granulosus. Okay. All right. So this is the life cycle. Again, this is the definitive host and this is the intermediate host. Okay, I don't want you to focus too much, at least for my passage. You're not going to focus too much on this cycle, the one that goes on between the dog and the sheep. But what you should know is that sometimes accidentally, the human can accidentally ingest some of the embryonated feces. Okay, or sorry, embryonated eggs in the feces, and then that can cause the hydatid cysts. Okay, so once these oncospheres release in the colon, they can then migrate to different areas in the body. So depending on where they go, they can have different presentations. So again, we said the most commonly affected is what? Who can tell me?
What, can you repeat the question?
What is the most common area of infection? Liver, exactly. So how do you diagnose it? You diagnose it through something called Cassoni's test, which is immunodiagnosis. So basically, Cassoni's test, Cansoni's test, what you're going to do is you're going to take some of the hydatid fluid from a different cyst. So probably in a dog, you're going to take some hydatid fluid, and you're going to inject one forearm subcutaneously with the cyst. and they're going to inject the other form with saline, okay, as the control test. So you're going to inject one arm with saline just as a control, and then the other arm with hydatid cyst. If a little blood form or if a little reaction happens within the next 30 minutes of this injection of the hydatid fluid, then that means that this person has been infected with hydatid cyst before, and that's because their body already has the antibodies against these antigens. Okay, that's Cansoni's test. You can also see calcified cysts in imaging, similarly to the actually, yeah, it is the Echinococcus granulosus, or you could, again, it's the same thing, ELISA for the antibodies or the proteins. Okay, so this is a picture of what the liver would look like after infection with Echinococcus granulosus. Okay, so these are hydatid cysts in the liver. You can see these protoscolex from the cyst. I don't think this is very high yield. We were never asked about it last year, but it's just something to know that basically what they're called inside of the cyst are protoscolex. Okay, protoscolex, and that's what they look like. And again, this is a picture of Echinococcus granulosus. One second. Okay, does that make sense? All right, we're done, almost done with the cestodes. Then we're going to finally do the trematodes. So let's do the case presentation. So Fatima presents with right upper abdominal discomfort and a noticeable slowly growing mass in her abdomen. What is this? This is a liver hydatid cyst. Okay, discomfort is a dull ache that worsened with deep breaths or bending over. She was a shepherd, right? Shepherd. So she's interacted with the sheep and all that stuff and dogs in a rural area and has frequent contact with sheep and farm dogs. There we go. Fatima denies any recent travel, but reports drinking water from an untreated local source on occasion. Okay, so there's multiple ways that she was able to accidentally ingest these eggs. She has no known allergies or past medical history, and she's not taking any medications. Okay, so again, hydatid cysts, most commonly in the liver. Okay, ingestion of eggs in food contaminated with dog feces and sheep and intermediate hosts. Okay, so that's Echinococcus granulosus, the dog tapeworm. Now for trematodes. I guess for trematodes we only have schistosoma, unless I'm mistaken. Right? It's just schistosoma.
Yeah, we only have schistosoma.
No. First of all, trematodes are also known as flukes. Okay, so schistosoma is the one we're going to be talking about. So there's 3 different organisms that we need to know for schistosoma. The first one is Mansoni, second one is Hematobium, and this first one is Japonicum. That's the word, right? And again, this is an indirect life cycle because humans are the definitive hosts, and then the intermediate hosts are the snails. Okay, snails. So the transmission occurs when free-swimming cercariae penetrate the skin. So Mansoni and Japonicum affect the mesenteric veins, okay? And then Hematobium affects the venous plexus of the urinary bladder. Who can tell me what is the main presentation of Hematobium, of schistosoma Hematobium?
Hematuria.
Hematuria, exactly. You can tell from the name, Hematobium, Hematuria. What about Mansoni and Japonicum?
Dysentery.
I guess dysentery.
Dysentery, yeah. So you'll find some blood in stools. Okay, that's because it's affecting the mesenteric veins around your GI tract, basically, your intestines and your colon. I guess, yeah, small intestines and colon. Okay, so this is by the way, this is what a picture looks like. This is a paired schistosoma adult. Like I mentioned, guys, with trematodes, most likely you're going to get worms that are hermaphrodites. I mentioned that at the beginning of the PAL. They're going to have male counterparts and female counterparts, or like genitalia. So this is what a schistosoma would look like. It's sort of paired. So you'll find the female inside of the male. Sort of weird. Anyways, this is the life cycle. You'll find the free-swimming cercariae released from the snail, the intermediate host, and then they penetrate the skin, and then they go into the circulation where they migrate to the portal blood or portal circulation in the liver, and they mature into adults. Okay. Now, once they finish maturing in the liver, they're going to migrate, basically Mansoni and Japonicum, they're going to migrate to the mesenteric venules, and the Hematobium, they're going to migrate to the venous plexus of the urinary bladder. Okay, so snails, from the snails, you're going to get these free-swimming cercariae. That's the effective stage, obviously. And then the diagnostic stage would be these mature adult worms in the liver before they migrate to either the mesenteric venules or the urinary bladder venules. Okay. All right. So the diagnostic stage, again, you have these eggs in the urine or feces. Okay. Now, it's important to know what these eggs would look like. So Mansoni, what you need to know is that it has a lateral spine. So the egg has a spine, but it's more laterally displaced, as you guys can tell. It's more lateral. So it would look something like this. That's Mansoni. While hematobium, it's terminal, which means it's right at the edge of it. So it's like this. That's hematobium. Now, Japonicum also has a lateral spine. But it's just very, very small. You can barely tell that it has one. So it's just a good way to visualize it by telling yourself, okay, Mansoni has a lateral spine. Hematobium has a terminal spine. Okay, so that's how you remember it. And these are what the pictures look like. So these are Mansoni eggs. You can tell because of the lateral spine. This is hematobium. So it has the terminal spine. Mansoni has the lateral spine. And as you can tell, I'm not sure if you can tell, but Japonicum has a very small lateral spine, but it's barely noticeable. So we just don't even talk about Japonicum in terms of it having a spine. And then these are the paired Schistosoma adult worms, obviously. Okay. Do I have any questions about trematodes or cestodes? Anything about flatworms? So from right here, Tinea solium. Again, Tinea saginata. This is Teneaceus. This is what it would look like. This is Tinea solium, cysticercosis. This is Echinococcus. It's going to cause the hydatid cysts right here. One of the shortest tapeworms. Schistosoma. Again, you have hematobium and Mansoni and Japonicum. Japonicum and Mansoni are going to cause blood and stool, and hematobium is going to have hematuria. Okay. So a 24-year-old male, Ahmed, presents to the clinic with complaints of blood in his urine. Okay, immediately we know what it is. Lower abdominal pain and increased urinary frequency. He notes that the blood is especially noticeable at the end of urination. Recently traveled to Egypt where he swam and bathed in freshwater lakes. Okay, so from snails, you get these cercariae that are going to penetrate the skin in freshwater lakes. He reports no fever, chills, or nausea, but describes mild fatigue and occasional burning pain with urination. Again, we know that it's hematobium. Okay, and again, this is the first aid table. Now, who could tell me? Now, if you had the same history of going to Egypt and swimming in freshwater lakes, except he presents with stiff neck and disorientation and confusion.
I think that would be Naegleria fowleri.
Naegleria fowleri, perfect. Okay, now somebody else. If Ahmed went to Egypt, swam in freshwater lakes, but he wears contacts and he got visual disturbances. Somebody else who can tell me.
The amoeba one, I think Acantharia amoeba or something.
Acanthamoeba, exactly. Acanthamoeba. Perfect. Great job. Okay, our final round of questions, and then inshallah we're done. Which of these organisms causes hematuria? We just talked about this.
The first one.
Hematobium. Exactly, perfect. So schistosoma. Who can tell me what the rest are very quickly?
The second one is the Echinococcus. The third one is the Tinea. Tinea saginata or the solium?
This is solium, but again,
Solium.
you really don't need to tell the difference that much. You'll know from the clinical presentation. Okay? Okay. Which of the following organisms, somebody other than Yasser, inshallah, can cause this presentation? This one right here. And then I want somebody to also tell me what the rest of the pictures are. Who can tell me which one causes this presentation? First of all, who can tell me what this is called, this presentation?
Is it a liver abscess?
It's liver something. It's not abscess. Liver abscess would be Entamoeba histolytica. But this is not liver abscess. This is liver cysts. So if you guys remember liver cysts, we saw them in Echinococcus granulosus, right? So the answer here would be B. Or I guess the second one. There's no letters. Okay. Who can tell me what the
Is
rest of
it
them?
the one with the dog?
Yes, the one with the dog, Echinococcus, can cause hydatid cysts. So again, this is what it looks like, causes hydatid cysts, most commonly in the liver. Dogs are the definitive hosts, so it's most commonly seen in shepherds and people who interact with dogs and sheep and stuff like that. Okay, this is the case presentation if you guys want to. By the way, you'll have access to my slides, inshallah, if any of you guys want to go through it. But I do recommend that, as a final review, you guys open ChatGPT just like I did here, and you look up the clinical presentations of anything that you're unsure about. Okay. So who can tell me what the rest of these organisms do?
The first one is Tricora.
Okay, Tricora, yeah.
Second one is Enicoccus something. And the third one is Taenia solium or saginata. The fourth one is I'm not sure.
This one I put there. This one I put there as a yeah. So this one is not. I know that it says here Cestodes and trematodes, but I wanted to trick you guys a little bit. This last one is actually a nematode. It's a roundworm, Centrobes vermicularis. Perfect. All right, we're done. Alhamdulillah. Does anybody have any questions?
Allah يعطيك العافية حبيبي.
Allah afikum. Allah afikum, guys.
حياتك
Inshallah, I
العافية.
know POD is a tough block, but inshallah, if you guys study well and you make sure you're looking at the pictures, you're memorizing what the pictures look like, inshallah, you're gonna be all good. Okay. If you have any questions, here's my number, here's my email. Reach out at any time, and please don't forget to fill out the QR code. Let me know what I could do better. And ya'tukum al-afiyah, guys. Best of luck.
لا بس thank you so much رواد ما قصرت.
يعطيك العافية حبيبي. والله I appreciate it. Thank you.